Good evening once again and welcome to this webinar. To kickstart this session for the day, with great pleasure, I'd like to welcome our esteemed guest and our first speaker, Dr. Rajiv Mani. Dr. Rajiv Mani is the Vice Chair of Clinical Research in the Department of Ophthalmology and Vision Sciences, University of Toronto, and VR surgeon at St. Michael's Hospital, the Hospital for Sick Children, and the Kensington Eye Institute in Toronto, Canada. Dr. Muni has over 140 research works and has won several awards for his research and teaching, including the 2018 Innovator of the Year Award by the Eye Physicians and Surgeons of Ontario in recognition for his groundbreaking work in the randomized trial comparing pneumatic retinopexy and vitrectomy for primary reg RD. Today he'll be sharing his experience about pneumatic retinopexy with simple and complex cases, the Toronto technique. Over to you, sir.
Thank you very much, Ridhima, and appreciated Vaibhav for this kind invitation. So today I'm going to talk to you about patients who can have pneumatic retinopexy with various indications. So this is a classic patient with superior breaks within 1 clock hour. And all of you would potentially consider pneumatic retinopexy in this case. But with our expanded techniques, we can also take on very challenging cases such as this, for example. And I'm going to show you some of our approaches to deal with these types of cases. First of all, let's talk about some of the data. We carried out the pivot randomized trial, which compared pneumatic retinopexy to pars plana vitrectomy for routine cases, and ETDRS visual acuity was superior at every time point for pneumatic retinopexy compared to vitrectomy, including the 1-year endpoint by 5 letters. And this includes patients in the vitrectomy group, all of which who had cataracts that were visually significant. What was most surprising, however, was that in the vitrectomy group, patients also had significantly worse vertical metamorphopsia, and subsequent studies have also shown worse anisoconia. And this goes to the fact of the mechanism of how the retina is reattached with vitrectomy compared to pneumatic, which has an impact on functional outcomes. So today I'm going to be focusing mainly on the technique of pneumatic retinopexy and how you can achieve similar outcomes in your practice. So let's start with a video. I hope the audio is there.
A very old book.
So initially we apply some conjunctival anesthesia, usually in the location that we want to do the injection. We typically want to do the injection away from very large breaks, because if you happen to get fish eggs, you don't want the fish eggs to rise where that break is. So in this case, we were going to inject supranasal, either supranasal or supratemporal. The AC tap is very critical. Here you can see that I'm really flattening out the AC. I took out the plunger from the TB syringe, and with the 30 gauge needle and the TB syringe, I was able to take out 0.3 cc's. We then do the gas injection as usual, 3.5 to 4 millimeters back. We go in halfway in and then pull back so that only the tip is in the eye, and then we inject the gas into an ever expanding gas bubble. And here you can see we always put in 0.3 more than what we took out, but never less than 0.6 of pure SF6 gas. We then want to check the central artery perfusion. Often I will re-tap just to get things going so the patient can be discharged. We often will re-tap, and it's important to go inferiorly over iris. Be very cautious with the iris and the lens at this point, and come in and out very slowly. And so that's the basic technique. I prefer SF6 gas because you have a very rapid expansion, and then it goes away very quickly in 12 days. Whereas with C3F8, it takes a long time for the gas to expand, and then it's there for 38 days, which is much longer than what you need. We always laser any pathology in attached retina immediately before the gas bubble injection. So we'll do the laser first, then we put the gas bubble in and position the patient. But any pathology, lattice, vitreoretinal tags, any atrophic holes, anything like that, even large breaks in attached retina, you laser first. Regarding the injection technique, we go halfway in. It's a 3 cc syringe with a 30 gauge needle. Go halfway in with the 30 gauge, then pull back. So only the tip is in the eye, and then you inject the gas into this ever expanding gas bubble. We like to do the steamroller maneuver so patients can be face down for 4 hours for fovea on and 6 hours for fovea off. And then they gradually raise their head 30 degrees every hour until the patient is head elevated. And this expresses fluid from the break, so the RPE pump has less work to do. It's very important to put patients on topical steroids, especially for the first week after. This reduces inflammation and reduces the amount of discomfort, and it makes the laser much easier. So now let's go through a few cases. We're going to go from simple to complex. So standard criteria are the basic ones. If you're just new to pneumatic retinopexy, stick to patients like this, single break or a few breaks within 1 clock hour, superiorly in the superior 8 clock hours of the retina. And the next step would be the pivot criteria, which is where you have extensive pathology in attached retina. You can have multiple breaks elsewhere in attached retina, but still within the detached retina, the breaks have to be within 1 clock hour. And then as you get more experience, you can tackle cases like this, which are extended criteria, where you have inferior breaks or multiple breaks spanning more clock hours. So let's go through some real cases. This is a patient with a superior break, inferior lattice degeneration. We applied laser to the inferior lattice. And here you can see the next day, we got fish eggs, unfortunately, but still the retina attached at 24 hours. At 2 weeks, you see the bubble is gone with good laser around the break. This is a patient who does not have a PVD, young patient, 22-year-old male, fovea-threatening symptomatic detachment with that atrophic break. This is easy to fix with pneumatic. Face down for 6 hours, then side positioning, laser the break the next day, easy. Okay, here's a patient with a chronic detachment. You know, chronic detachments with PVR are fine as long as there's no traction on the break. So in this case, you see a subretinal band in the macula, but the break was superiorly and there was no traction on the superior break. So here you could see that we were able to laser the superior break and achieve attachment without any additional surgery. Here's a good laser reaction down the line with a good attachment. Here's a patient, bullous inferior detachment. It doesn't matter where the fluid is, where it matters is where the break is. So in this patient, the case, the break was temporally, older patient. We did face down for 6 hours, then side positioning. And here you can see the retina attaching over the next few days with a good outcome. This was a young patient with a myopic detachment with a large nasal flap tear here you can see. So here we did face down positioning and then side positioning. And the same day the retina starts to improve. And then over the next few days, achieve attachment with good laser. So those were all pivot criteria or standard criteria cases. Now let's get into the next level, which is extended criteria. So here, these are breaks more than 1 clock hour. So this is generally pretty straightforward as well. Here you can see a larger break supratemporally, and we then applied laser for a few clock hours on either side of the break as well. Here's a patient with atrophic holes, and you can see, multiple atrophic holes temporally. Again, we will do face down positioning and then side positioning. And often these will do very well with pneumatic retinopexy. And again, there was no PVD in this case. And now let's get into some complex cases. So here's a patient with choroidal detachment, superior break. These are ideal for pneumatic retinopexy with a superior break because you put a bubble in, it addresses the pressure issue and also will tamponade the retinal break. Here you can see over the next day, choroidal is getting better, the detachment's improving, and then we can apply laser, and we achieved a complete attachment with good laser around the retinal break. This is a patient with a large radial tear. So these are a little more tricky because you need to make sure the bubble is covering the break. So actually the first day it got much worse with the gas bubble, but fully by that gas bubble, the 0.6. So we injected a second gas bubble. When we do sequential gas bubble, we usually inject that on day 3. And with the second bubble, you can see that we achieved full attachment and good laser around that radial break. Here's a patient with multiple breaks. Patient had multiple superior breaks and multiple inferior breaks in attached retina as well, almost 360. And here we applied laser inferiorly first, immediately before the gas injection. Then we did our gas injection. We did sequential positioning and were able to laser all breaks and achieve retinal reattachment. And here you can see down the line. GRTs are fair game with pneumatic. If you understand the principles of how gas bubbles and gravity work, if you put a bubble in this eye and put them face down, it'll almost immediately attach. This is 15 minutes after the bubble injection. The GRT has unraveled, and at 60 minutes, again, you can see a almost fully attached retina At 1 day, retina fully attached. We then started the laser retinopexy. At day 2, we did more. And at 1 week, you can see full attachment with good laser all around the retinal break. I want to show you a video. This is a patient, 12-year-old girl with an inferior dialysis. She was referred to me. She had barricade laser elsewhere. The barricade kept being broken through by this inferior dialysis detachment. So here's a video showing the procedure. So in children, it's very important to talk them through it. All a pneumatic is a topical anesthetic, a subconj anesthetic, an AC tap, and an intravitreal gas injection. When you break it up into those 4 things, it's very simple. So you have to talk the patient through. I put the topical and the subconj. Usually after that, they don't feel anything.
So the key is now you won't feel anything here too much. Just try not to move all of a sudden, okay? You're doing very, very well.
So here we go inferiorly over iris.
Good job.
Keep the needle parallel.
Excellent.
And I'm using the plunger to dome up the cornea so I can squeeze out as much fluid as possible. The AC is flat, so I come out. We mark 4 millimeters. And here we are injecting the gas, minimum 0.6 cc's of pure SF6. This is a patient who has no PVD, a vitreous filled eye, and this is completely safe to do. It does not induce traction or new breaks. This is pretty much a myth. I can tell you this after having done thousands of pneumatics. So then we will inject our gas bubble, and here you can see.
Did it hurt at all? Not at all? Nothing? Not even one part? Wow.
So this is an ambulatory procedure. We then examine, make sure that the central retinal artery is perfused and the patient achieved attachment. Here you can see we actually did require a second gas bubble to get to the 6 o'clock location. And then after a couple days, the retina was attached along the dialysis. So we didn't need to barricade anymore. We're actually treating the break, which is the fundamental concept in pneumatic retinopexy. And here we used ultra wide field OCT to help show us where the retina was attaching in a zipper-like manner. And we were able to treat all along the dialysis here. This is a 12-year-old girl with Stickler syndrome, total retinal detachment, and had the GRT from 10 o'clock to 5 o'clock. You can see the inferior aspect of the GRT. So here and this patient, actually, her father had VITs in both eyes, was blind in one eye, then the other eye was still seeing 2200. So less invasive approach. Here we did a pneumatic retinopexy as our first line approach. We said, it's 50-50. It may not work, but we have a lot of experience with it, and at least we can improve the situation. If it doesn't work, the surgery will be easier. Usually we can attach a large part of the retina. So here we injected 0.7 cc's of gas. We had to do different types of positioning because it was, again, like a 7 or 8 clock hour GRT. This is on day 1, the fovea is attached. And then you can see this is my fellow here. She's performing laser in the clinic. And, children do very well, sometimes better than adults, actually, with laser retinopexy. We typically use indirect laser. This is the best way to achieve laser retinopexy for pneumatic cases. And here you can see on day 2, you see the GRT edge. We put a lot of rows, maybe 5-6 rows of laser. There was still some nasal fluid on day 2. We had to adjust the positioning. Here you can see at day 6, the laser starting to scar in. One single bubble of SF6, no vitrectomy, no buccal, no silicone oil. And here you can see a good laser reaction, 360 degrees, and the patient achieved a good attachment. This is my last case, a GRT folded over. We inject the gas bubble. Here you can see day 1, it completely attaches. We lasered the temporal side. There was still fluid from the nasal side. And so then I alternated positions side by side every 4 hours approximately. And here you can see that nasal horn still open, but I was able to, on the first day, to get that laser all along the superior GRT. So I was only worried about the horns. And so then we achieved complete attachment and finished the laser. Here you can see a beautiful attachment. The fundus autofluorescence shows no slippage or displacement or anything like that. So I'll summarize by saying that primary anatomic reattachment rate is lower with pneumatic versus vitrectomy. We all know that. The difference in the pivot trial was 12%. That means if you believe in vitrectomy first, you would have to do 8 vitrectomies to save one person from needing an extra surgery, but you're subjecting those patients to worse functional outcomes. We know visual acuity, distortion, anisoconia is better with pneumatic retinopexy. So where are you on this curve? As you go from the left to the right, it's simpler and simpler cases. If you take only one break detachments, you see the difference between vitrectomy and pneumatic is 88 versus 90%. If you go more complex like GRTs, it's going to be 66 versus 80%. The difference will widen, but at most it becomes about 12% difference for complex cases. For easy cases, the difference between vit and pneumatic is maybe 2%. So, maybe you're not going to start with cases like this, but cases like this are a no-brainer. We know that functional outcomes are worse with vitrectomy with no substantial advantage in terms of reattachment rate. So I'll just end with this video.
Jo, hier vorne. Was ist dein Handwerk?
Ich bin Töpfer.
Und du, Arcadia? Was ist dein Handwerk?
Herr, ich bin Bildhauer.
Und du?
Ich bin Schmied, Herr.
Spartiaten! Was ist euer Handwerk? Nun, alter Freund, ich habe mehr Soldaten mehr als du.
Thank you very much. I really appreciate the invitation. Again, I wish you all the best for this great meeting. Thank you.
Thank you so much, sir, for your wonderful experience. I guess one of the major criticisms for pneumatic retinopexy is the lower primary reattachment rates. And I guess with these results, more and more of us would like to try it. Sir, how often do you re-inject gas in these patients? And how much would you want to wait before you go in for your rescue surgery?
Yeah, so usually I'll re-inject gas in patients who are failing, the majority of the time we only need one gas bubble in pivot trial or single break cases. But as you get more complex, like a GRT, it's very often, maybe 50% of the time, I'll use a second gas bubble on day 3. I think that after the second gas bubble on day 3, that SF6 will expand by day 5. So one of the keys to not having bad outcomes in pneumatic is to move very quickly. So once it's failing on day 5, I have them in the OR within 1 or 2 days. So this way, I don't lose anything. If it doesn't work, I still achieve the same outcome as if I did primary surgery. And if it works, I know that even though there was an initial chance of a lower single operation reattachment rate, I know that my functional outcomes are better. So, a lot of times patients will say, well, in private patients, they're paying customers, like, in certain different healthcare systems around the world, why would I, patients aren't going to be happy with that. But at the same time, you have to explain to patients that you can have a 10% higher reattachment rate with vitrectomy, but you will have worse vision, more anisoconia, more metamorphopsia, a cataract, and all these other things. So you have to balance what is important for each patient. If you have a patient from the village 3 hours away who's never going to come back, of course, go for surgery. But if you have an engineer who lives next to your eye clinic and they understand how to position, and they're going to get a better result if you do pneumatic. And it is more work for the patient, for the doctor, but outcomes are worth it. No one said everything has to be easy.
Right. So we have one of our surgeons has asked a question. Can you please explain the steam rolling technique? So do you have any particular rotation? I mean, how many hours of face down and how many hours of lateral position?
Yeah, so if you do face down, so steam rolling, I do recommend 4 hours for fovea on and 6 hours for fovea off cases. Then you raise your head 30 degrees every hour until they get to the head elevated position. If it's a side break, temporal or nasal, I would do 4 or 6 hours, depending on foveal status, face down, and then side positioning to the side to get the coverage of the retinal break. So that's usually how we do it. I mean, there's more complex ways, like, for example, when you have an inferior break in attached retina, infrotemporally, for example, and a superior temporal detachment, you can also steamroll on the side to push the fluid nasally so it doesn't get displaced down to the inferior break. But initially, I would stick with 4 or 6 hours face down and then gradually raising your head.
Thank you so much, sir. I guess we can move to the next presentation.
Thank you, Dr. Ridhima. We'll quickly move on to our next talk of the session. Please join me in welcoming Professor Hassan Murtada, veterinary consultant at Cairo University. He is a member of Egyptian Ophthalmology Society and Egypt Veterinary Society. And on an international level, Dr. Murtada is a board member at the European Veterinary Society. He is involved in many scientific programs and is closely working with national societies to develop a comprehensive retinal education in national conferences. It's a privilege to have you here with us, Professor Murtada. Over to you.
Good afternoon, everybody, and thank you for the invitation. It is really a pleasure to be a member of this meeting. My talk is about advanced PVR and pearls for management. Okay. Well, in doing PVR surgery, you have to optimize visualization. And for speaking for myself, I found that the wide-angle digitally assisted visualization system is very suitable in dealing with this these complicated cases, as it provides high magnification with a high resolution and high depth of focus. There are many classifications for PVR, but the one with the clinical importance is the classification into posterior PVR located to the posterior insertion of the vitreous base, and it is more common in primary PVR and anterior PVR, which is located anterior to the insertion of the anterior border of the vitreous base, and it is more common in recurrent cases. First, we have to manage the anterior segment. This is a patient, a young boy with a Stickler syndrome who suffered recurrence of detachment following vitrectomy. And you have to clear the pupillary area in order to have a perfect visualization of the posterior segment. Some cases are more complicated, like this case, who suffered a car accident and they underwent secondary IOL implantation. And he presented with this opaque cornea and the Yamani technique. So you have to remove the opaque cornea, remove the lens, fix the temporary keratoprothesis, and then manage the case. Here I'm injecting helium into the behind the keratoprothesis in order to push the retina behind. Usually I start by managing the posterior PVR using excision of the vitreous gel, pigment clumps, and transvitreous traction bands, peeling of the posterior hyaloid as much as you can using triamcinolone, peeling of all epiretinal membranes, extended ILM peeling with or without PFCL, and then you inject PFCL to stabilize the already mobilized posterior retina. This is how to peel the posterior hyaloid. This is a PVR is localized to the posterior pole, a macular pucker, but you can see that the posterior hyaloid is adherent to the posterior retina, and the epimacular membrane is actually on the back surface of the posterior hyaloid, and this is can be removed by application of vacuum from the vitrectomy probe. This is another case of epimacular membranes of a recurrent case following scleral buckle, and it has to be removed to free the posterior pole. And after this, you have to inject triamcinolone to look for remnants of the posterior hyaloid, and this is followed by ILM peeling. This is how to manage posterior epiretinal membranes. I injected brilliant blue to stain the membranes, and then using the ILM forceps, and this is under the head-up surgery using the yellow filter, which enhances the visualization of epiretinal membranes. The general rule is to peel from posterior to anterior, but with PVR, the membranes can be peeled in any direction, taking care not to apply much traction to the posterior or the anterior retina. This is after stabilization of the posterior retina, removing membranes more anteriorly. And the more you remove the membranes, the more you inject PFCL in order to stabilize the retina. Here I'm using the green filter, which also enhances the visualization of membranes and decreases the glare to the surgeon's eye. Also, the epiretinal membranes were peeled extensively, and this is one of the key to success of surgery, is to leave the retina completely mobile. Peeling of the eye lamp is crucial in this pathology because it is a scaffold for ciliary reproliferation. So you have to peel the internal limiting membrane external as much to the periphery as possible, and then the retina is stabilized with PFCL. Again, starting peeling with the retina still detached and using the optic disc as an axis for the peeling facilitates the internal limiting membrane peeling. You can do the same under PFCL and you can reach the same result. In this case, which is a combination of PVR and macular hole, we do not remove the internal limiting membrane, but we use to fashion the multi-layer flap, also peeling the internal limiting membrane from all around the macular hole, bringing the internal limiting membrane over the macular hole and stopping around 300 microns from the edge of the hole. The flaps are brought over the hole in order to assist in the closure of the hole. And then you can extend the eye lamp peeling to the periphery. The more you remove the internal limiting membrane, the more you are sure that this area will not suffer from recurrence of epiretinal proliferation. This is an interesting case of a young boy who presented with this detachment. You can see that it is a closed funnel, but there are no epiretinal membranes. The posterior hyaloid was removed using this serrated forceps, and then again, brilliant blue is injected in order to make sure that there is no epiretinal membrane. After injecting PFCL, we discovered the presence of extensive subretinal proliferation. I started peeling the internal limiting membrane, and it was attached really to the posterior hyaloid. So as I peeled the internal limiting membrane, I also peeled the posterior hyaloid, and it was peeled to the retinal periphery. This is the case of a closed funnel. Usually there is a plug closing the funnel, which has to be removed in order to open the funnel, and then the peeling is managed from posterior to anterior, and this circle of fibrous tissue proliferation demarcates the junction between the anterior and the posterior PVR, and sometimes you can peel it, sometimes you have to segment it, but you have to stabilize. Also, again, the posterior pole, stain the internal limiting membrane and peel it as far as peripheral as possible. And then we deal with the anterior PVR. You have to excise the contracted basal vitreous gel, peel the epiretinal membranes. You may have to do a retinotomy with variable extent, removal of subretinal proliferation, and reattach by PFCL. This is the case of anterior loop traction. You can see the probe is used to open the folds made by the anterior loop traction. Here I'm using the chandelier light, which, by the way, is always present in doing these complicated cases because you may have to work bimanually at any time, removing the peripheral epiretinal membranes in order to free the anterior retina. But some of the peripheral membranes were found difficult to remove, so we resorted to vitrectomy. Shaving of the basal vitreous gel is crucial and a critical step that should be done before starting doing retinotomy. And this is the case of a recurrent PVR. You can see how the anterior PVR was left behind. It was peeled using vacuum from the vitrectomy probe. And then again, the anterior part of the retina was stiff, and we have to perform retinotomy and retinectomy of variable extent depending on the severity of the contraction. Again, this is peeling of the peripheral membranes using the serrated forceps, working in different directions and removing also subretinal strands. And at the end, the peripheral retina is so contracted, and so retinotomy was performed in order to relieve the traction, taking care to remove also the anterior flap. And in this case, the pars plana epithelium was also detached. This is the case of Stickler syndrome with recurrent retinal detachment following scleral buckle. Again, there is contraction. On doing the retinotomy, it has to be as large as possible. So overdoing is better than underdoing, and you have to connect the edges of the retinotomy to the ora serrata in order to relieve both the anteroposterior and the circumferential contraction. This is again a case of closed funnel in a traumatic retinal detachment in a child with severe PVR. You can see how the posterior hyaloid is strongly adherent, but you have to use vacuum from the vitrectomy probe several times. I do not advise injecting triamcinolone at this stage because it may hide the behavior of the underlying retina. And you have to continue peeling epiretinal membranes as much as possible, injecting triamcinolone to identify more vitreous gel, and then injecting PFCL to open the funnel, removing internal limiting membrane. Also, as I said, extended removal. And this is extended as far peripheral as possible. And you may use the Thanos scraper to remove shreddy membranes that cannot be held with forceps, and then peeling it to the periphery. And then working anteriorly in order to release the peripheral retina. And at some time, you have to work bimanually, because with this, there was a giant retinal dialysis, and then working bimanually. And the best way to deal with this vitreous membranes in presence of mobile retina is to use two forceps and one hand over the other, or using one forceps to pull the vitreous membranes and then undermine the membranes from the underlying retina. Subretinal proliferation is the last step in management of PVR. You can remove the subretinal proliferation by different methods depending on the extent, but sometimes it was so extensive subretinal proliferation causing traction and has to be removed through a peripheral retinotomy. Try to do the retinotomy as peripheral as possible to save much of the retinal tissue. And then the retina is inverted here under the chandelier. We are making indentation, then using again two forceps to catch the extensive branching subretinal proliferation that were successfully removed, and then the retina is attached by injecting PFCL. Again, this is an advanced case. This is the last eye of this patient. He underwent repeated vitreoretinal procedures, including silicone oil injection, silicone oil removal, and this is the end result with extensive epiretinal proliferation. So you can see that there is a cord-like subretinal proliferation that has to be removed, and then it was cut and completing 360 retinotomy because the peripheral retina was contracted, was subretinal silicone oil that was removed, epiretinal proliferation, subretinal proliferation. So in order to mobilize the retina as much as possible, sometimes there is folding of the retina around the optic disc when you reattach the retina, and you have to look for the reason. And this case demonstrates how there may be a fold around the optic disc. And I discovered that the retina was incarcerated somewhere. You have to rotate the retina using the TAN scraper. You may have to do a small radial retinotomy in order to reattach the retina and finally perform PFCL, silicone oil direct exchange, and endolaser. Thank you for your attention, and thank you again for the opportunity to participate in this wonderful meeting. Thank you.
Thank you, Professor Murtada. That those are some wonderful videos. Now, some of the cases were like very like surgeons' nightmares, and you managed them beautifully. I think some of the important take-home points will be to peel as much as possible, use filters and use dyes, and just peel whatever epiretinal membrane is possible, or do an extended ILM peeling. Professor Murtada, I had few questions for you. We sometimes encounter very flimsy membranes intraop that is just difficult to grasp. How do you manage those cases? Do you wait for them to mature a bit so that you can easily peel them off, or you have any tips intraop to tackle them?
You may try the use of the TAN scraper or the Vinesse loop in order to just scratch these or immature membranes from the surface of the retina, but still there are some membranes that are difficult to catch and difficult to peel. You may wait for some time if there is most of the membranes are immature. But if the macula is detached, you have to interfere. So you do not wait. If the retina is attached, for example, if the eye is filled with silicone oil and there is recurrence under silicone oil, and the macula is attached, you may wait for 3 to 4 weeks till the membranes are mature, and then you start, you reoperate. But if the macula is detached, you have to operate earlier.
Thank you, Professor Murtada. Just a final question, your choice of tamponade. Do you use PFCL silicone oil sandwich, or do you have an experience with heavy silicone oils?
Really, I use the regular silicone 2000 centistoke in all cases. I have tried the heavy silicone, but I think they add problems more than solving problems. So I stopped using the heavy silicone oils and I'm using regular silicone. And I believe that the main issue or the key is to release as much as possible of the traction and to remove all membranes and protect the retina and protect the macular area or the posterior pole by doing extended ILM peeling.
Thank you so much, Dr. Murtada. I think we can go on and on this topic, but I'm afraid we're out of time. So we'll move on to the next talk.
Thank you, Dr. Niroj. Good evening, everyone. It's an honor to introduce our next speaker for the evening, Dr. Barbara Parolini. She's a dynamic retina surgeon and director of VR services at Istituto San Anna di Brescia, Italy. And she has contributed immensely to the field of vitreoretina through her research. It'll be a pleasure and privilege to listen to her talk about macular buckle in myopic tractional maculopathy. So I'll be sharing her presentation, and ma'am is available for questions after.
Dear colleagues, thank you for allowing me to present this talk on myopic traction.
Ma'am, you didn't share your screen.
Yes, I am just doing it. Just give me 1 minute.
Ma'am, click on share screen button, then click
Yes.
on share sound, then click on share.
Yes. I hope it's visible to everyone.
Dear colleagues, thank you for allowing me to present this talk on myopic traction maculopathy. I will call it MTM. I want to redefine with you what is indeed a successful treatment.
Ma'am, please unmute yourself because your voice is not coming. Dr. Rachita, ma'am, please unmute yourself because, yeah.
The nomenclature, the average visual
Now audio is coming.
diagnosis per each stage.
Should I
Stage 1.
restart?
Dear colleagues, thank you for allowing me to present this talk on myopic traction maculopathy. I will call it MTM. I want to redefine with you what is indeed a successful treatment. But first of all, let me remind you that we cannot speak of MTM as a whole and unique disease. I have published a few years ago this new myopic traction maculopathy staging system. And this is the table summarizing all there is to know on MTM, the nomenclature, the average visual acuity, and the prognosis per each stage. Stage 1A shows the evolution of inner schisis inside the retina. Stage 2 shows the schisis deeper in the outer layer. In stage 3, the schisis is combined to detachment. And in stage 4, the retina is completely detached and there is no more schisis. While this is the progression on a plane perpendicular to the fovea, the disease can progress also tangentially to the fovea. So for each of the 4 stages, in stage A, the inner fovea is intact, but the disease can progress to a lamellar macular hole in stage B, and then to a full thickness macular hole in stage C. The MSS has been validated among a small group of ophthalmologists first, but the international validation has been published recently. So how to define the stage? Very simple. Look at the macula first and select 1, 2, 3, or 4, and then look at the inner fovea and select A, B, and C. As an example, this is stage 1C. The macula has just inner schisis and the fovea has a full thickness macular hole. In this case, we see an outer schisis and the fovea is intact, so stage 2A. In this case, the retina is fully detached and there is no macular hole, so stage 4A. In this case, there is a combination of schisis and detachment with a full thickness macular hole, stage 3C. And there are stages in transition. The artificial intelligence can help you to define the stage, but believe me, it is much simpler than that. You have to remember that MTM is an evolving, dynamic, changing disease. It is never the same in the same eye. This is an example of an eye checked in May last year. Just in a few months, the eye evolved from stage 2A to 3A with a combination of schisis and detachment. This is another example of evolution from stage 3A to stage 4C. What about spontaneous improvement in MTM? Yes, it might happen. This is an example of a patient in stage 3A in 2014. She improves spontaneously to stage 2A 1 year later, and then to stage 1A 3 years later. But then if you wait enough, usually the disease relapses and starts to progress again. What about treatment? To treat or not to treat? And which treatment should we use? I observed that many colleagues seems to have given up upon myopic eyes, but the good news is that these eyes can see with the correct treatment. What does the literature report as successful treatment? This is just an example of a paper reporting a functional success in 60% of the eyes and 80% anatomical success. They also report that in more severe cases, you might have a total failure. This is another example reporting similar results. So look at these eyes with MTM operated with vitrectomy. For most of colleagues, this could be a success because the retina is indeed attached. But to me, this is not a success. The macula is atrophic. There is a full thickness macular hole. The patient has glaucoma secondary to silicone oil and vision is very poor. These are some of my publications on the subject, but I highlight this proposal of management customized per each stage. So this is the same table enriched in red with guidelines for management. In summary, I think that holes need an ILM flap, while schisis and detachment need a buckle. An ILM peeling and an ILM flap is extremely important, although very difficult in these eyes where there is no contrast and it is difficult to see the hole and to see the ILM. You see another example where the OCT as well as staining are extremely helpful. But definitely schisis and detachment, the retinal pattern of MTM, need a buckle. I presented in 2009 my first model of buckle, and then I have modified the homemade model to make it smaller and easier to implant. And this is the evolution of the model of buckle that I've been using. I switched to the AJL model in 2020, but I recently have changed the design to allow an easier implant and an easier removal if needed. So this is the last model of buckle that I have designed. Here in more details, you can see the holes which are used to implant the buckle and suture it in the supertemporal quadrant, as shown in this picture. I am now creating a nomogram to know at which distance to place the needle of the suture from the limbus based on the axial length. And this is an example of the nomogram I am collecting data these very weeks. This is an example of an eye, 30.85 millimeters long. You see 1 month preoperatively and the day of surgery is already evolving. I decided to place the suture based on the nomogram at 10.5 millimeters from the limbus. And this is the surgery showing you the suture of the buckle. in a non-reabsorbable suture with a spatulated needle. I pass the suture at the distance, and then the buckle is inserted in the superotemporal quadrant. After exposing the quadrant, you place the suture, fix the knot very tightly at the confirmed position, and basically the surgery is done. So then you can move with the other suture to tight and confirm the location. You can look through a flat lens or a panoramic viewing system. In this case, the patient had a full thickness macular hole, so I proceeded by creating an ILM flap. I could check it through the intraoperative OCT. I proceeded with the fluid air exchange, and surgery was over in less than 1 hour. In this video, you see the loading device that I am designing just to make the surgical implantation easier, but you have seen the procedure. I am collecting all the series of buckles that I have implanted since 2007. I have implanted 400 buckles roughly, maybe more. And now I have available data for 265, most of which have 15 years of follow-up. The anatomical success is extraordinary. When the buckle is well located, the anatomical success is 100%. The functional success, of course, has a range between 5/10 to 10/10 if there is no atrophy in the macula. Of course, there are complications, but I think they are totally acceptable. If you have decentration, you have to take the patient back to surgery if it's really decenter, but if the buckle is in the macula, it's not significant. If you have extrusion, then you can remove the buckle. If you have diplopia, you can remove the buckle. And if you have a mild limited hemorrhagic choroidal detachment, it will solve spontaneously. So the serious complications are severe choroidal detachment and this one single case of unexplained visual loss that that happened only in 1 over the 400 cases. So let's see some example pre and post-operatively. You've seen this pre-op, and this was the post-op 2 weeks after surgery. Pre-op, total detachment with the full thickness macular hole. This is how it looked just after vitrectomy, ILM flap, and buckle. This is pre-op on top and post-op on the bottom. You see 4 years later, the patient has a great vision with no scotoma in microperimetry. This is an example of pre-op, a very difficult case to treat in the deep staphyloma. And on the bottom, you see 1 year after surgery, the patient has a great improvement in vision. It is a patient that came with that type of eye already operated with vitrectomy, gas, then oil removal, then heavy silicone oil. She lost that eye and she came for the second eye with this detachment that had evolved, as I have shown before. So I have applied only buckle, and you see on the right the result with a great improvement in vision. Another example of a patient operated in one eye with a pars plana vitrectomy and silicone oil. She has a very poor vision with glaucoma. She came for the second eye with this type of OCT. I placed only a buckle, and this is how she looks, with great visual improvement, normal IOP. So this is another example of a patient that arrived with the same situation, anatomical and functional in both eyes. I operated with buckle the left eye, and then he left and was operated with vitrectomy in the other eye, and this is the result. So he came back for the second eye that had a failure and actually worsening because he developed a full thickness macular hole in the eye operated with vitrectomy. So I took him to surgery, and you see here just the main step of surgery with the creation of an ILM flap. And I placed a buckle, injected gas, and the anatomy could be restored. So does the buckle induce atrophy? It's been published that it might induce atrophy. But look at this picture. This is not atrophy developed after buckle. This is the natural progression of atrophy, which has been published by Kyoko Ono Matsui in great details. She says that atrophy is developed naturally in these eyes in 60% of the time. So this is an example of one patient of mine. You can see the progression preoperatively to 3 years later and then 4 years later. Yes, there is a mild development of atrophy, but not in the area of the buckle. While if you see on top, visual acuity and microperimetry have improved. This is another example where I show an improvement in vision and a very good microperimetry with mild progression of atrophy. And this is an example of comparing the natural history in one eye and the evolution years after buckle in the other eye. And in this example, you see one eye treated with buckle and the other eye treated with vitrectomy. So mild RPE changes might occur also, of course, after vitrectomy. I conclude showing you this great success with this patient, starting with an MTM in stage 3A with a detachment and very poor vision in the staphyloma, 2 years after buckle, and 1 year after phaco with implantation of multifocal IOL. He can see 10/10, unaided, far and near. This is what I defined success in MTM management. So to me, the reasons to use a macular buckle for schisis and detachment in MTM is that the anatomical success is extremely high with macular buckle. Visual acuity always improves, and the amount of improvement is limited only by atrophy or anterior media opacities or complication or amblyopia. Macular buckle helps avoiding the use of silicone oil, which is extremely dangerous in these eyes. The results are long-lasting and they stop the progression of MTM. So in the end, I think the new motto in MTM is stuff the hole and buckle the retina. Thank you.
Good evening, ma'am.
Good evening.
Thank you for elucidating that pathogenesis so beautifully, making it so simple for us. And also you make the surgery look very simple for all of us.
It is indeed. I care a lot to say that it should be considered simpler today.
Yes. Ma'am, one question from my side would be, since it's just a one-point attachment, I'm sure the scleral thinning in these cases is not much of a problem. Like in your experience, have you noticed a lot of scleral perforations or?
Okay, great question. Actually, no, fortunately, this is not a major or so frequent complication, but it might happen to open the conjunctiva and find some blue or bluish sclera. What I do, I place a tuto patch, meaning a patch of artificial scleral reinforcement. We can use a donor sclera, we can use tuto patch, whatever we think appropriate. And so I place a nice and wide patch, and I suture the patch where the sclera is not so thin. And then I fix the buckle to the patch instead of the original sclera looking, of course, for this centration.
Yeah.
Speaking about centration, I want to spend a word on this 100% data that I offered. I don't want to, appear too enthusiastic, although I am. I have very little certainties in our profession, very little, but it seems that MTM has a mathematical behavior, both in the natural history and after surgery. So I want to tell you, I care to tell you that the 100% anatomical success is true. Of course, it means that we can always reattach eschisis and detachment when we place a buckle and when the buckle is well centered. Everything needs to be perfect, of course, but the result in terms of anatomical resolution is really guaranteed. The limitation, as I stressed, is in the functional success, which can be enormous and very satisfying as long as the RPE and the choroid are good and the patient has no previous atrophy, as long as the media opacity is not so significant and there's no amblyopia. But those are not the majority of the patient. When you start operating these patients, you're very happy with the results, functional results as well.
Thank you, ma'am. Thank you so much. In the interest of time, I think we will go to our next talk. Over to Dr. Prakhar.
Thank you. Good luck.
Thank you, ma'am.
Good evening, everyone. This is my biggest honor to introduce the next speaker, who is incidentally my mentor and the person who I look up to. A teacher par excellence, is also the person who made me do my first macular hole surgery and sat patiently with me throughout the whole surgery. Please welcome Dr. Rajan Narayanan. He has numerous accolades to his name and is currently the Director of Human Resources, Anant Bajaj Retina Institute and Suven Clinical Research Center, LV Prasad Eye Institute, Hyderabad. It's a pleasure to have you over here, Dr. Aran. Over to you for your presentation.
Yeah, thank you, Prakhar, and very good evening to everyone. Thanks to the organizers for giving me the opportunity. I'll be talking about ILM peeling and also a little bit of the shark skin forceps. What are the differences between shark skin and the regular ILM forceps and how it can be useful in some difficult cases. ILM peeling actually is considered by many fellows to be the last frontier in the fellowship. And if you ask most fellows, they in the end of their fellowship, they're usually either looking at the other fellows, how many ILM peelings they have been able to do, or who is the first to get a case of ILM peeling. And it's not very difficult if we follow the principles, if we follow the steps and not consider peeling as just one step, and consider or break it down into multiple steps. And there are principles of surgery for each of those steps. And all the people on the right-hand side of this picture, this was during one of the graduation ceremonies, all of them have been my fellows, and I'm happy to say that all of them are excellent surgeons. And this is just a small group of the fellows. Prakhar just now introduced me. He was my fellow, and I'll be showing one of the videos actually made by Prakhar for teaching. There are quite a few similarities between what we call as capsulorhexis in cataract surgery and ILM peeling. If someone wants to call it ILM rhexis, I wouldn't disagree with that term of ILM rhexis. So in this capsulorhexis, as you see on the left-hand side, you first make a nick in the anterior capsule, and then you have to extend the nick that you have made in the anterior capsule. So let me just play that again. The first step is a nick in the center of the capsule, and then you extend the nick, and then you make a flap. So there are three steps: nick, extension, and then a flap. Now here in the cataract surgery, you can easily do it with, let's say, a cystotome, a bent needle, and at the most you penetrate into the cortex of the lens, which is not very critical here in cataract surgery. But unfortunately for a maculorhexis, you can't do this in a crude way. So what we are looking at in a capsulorhexis is that you can be a little bit crude, but in maculorhexis, you have to be very fine, you have to be very precise, very accurate, so that you don't damage the underlying critical retinal tissue. So this is the video which Prakhar actually made for teaching of ILM peeling. Unfortunately, the audio is not playing, but what he's trying to show here is the first step is to pinch and release so that you make a nick in the ILM or you break the ILM. And then slowly you extend the break in the ILM. Like I mentioned for the capsulorhexis, you have to extend the break in the ILM as is being shown right now. And Prakhar is moving the cursor in the video to show the large extent of the ILM, and then you create a flap. So there are quite a few similarities between capsulorhexis and ILM rhexis. But each step which has been shown has principles which need to be followed. Yeah, so this is a real case where it's in slow motion. The first step of breaking the ILM, you pinched and released, but you need to be very, very precise. You should know what structure are you pinching, should not pinch too much, and you never peel in the first attempt. You just don't grab and start peeling. And the magnification has to be relatively on the higher side. A lot of fellows attempt ILM peeling in a very slow, very low magnification, but that's not correct. It needs to be high magnification, and whenever we are working at a very high magnification, the depth of focus is very small. So your focus can easily go away if you are working in a high magnification, but that's the point. You need to be in high magnification, and you need to have very good focus. And the step where you see the ILM forceps grasping, mainly the ILM, is very crucial, because when you are grasping, actually you grasp some of the retinal tissue. You pinch the retina in the first step when you break the ILM. You just can't hold just the ILM and break the ILM. So you invariably pinch the retinal tissue or the superficial retina when you want to break the ILM. And this is an anxious fellow. A part of the ILM has been peeled, and we see that a lot of ILM tissue is still stuck in the forceps, and trying to get over with the surgery. You just want to get over, somehow peel the ILM and move on. It's a crucial step. You don't want to be staying around there, but the trick is to stay there. The trick is to be slow. It's like slow cycling. Initially in cycling, faster cycling is actually easier. Slow cycling is more difficult. But in ILM peeling, again, we should not be impatient. We should actually focus precisely, see what we are holding, what angle we are holding, and the structures, and be very patient in this step. So the sharp skin forceps, it's a relatively new design where there are laser etchings on the outer surface as well as the grasping edge of the forceps. They're very, very fine teeth, 10 microns by 10 microns into 5 microns. And it enables the surgeons to grasp only the intended retinal anatomy, that is the ILM. So with this sharp skin forceps, you can actually hold just the ILM when you are initially holding and pinching or breaking the ILM. and the force required to indent, to grasp the ILM is significantly reduced. As you can see in this picture here, and you can invariably hold just the ILM with this shark skin forceps instead of having to pinch and hold a big chunk of the retina to break the ILM. This is a better diagram which shows the original concept, the ILM pinch concept, which is lower down, that is in the bottom figure, that you can easily hold the ILM by the friction induced by the surface of the shark skin forceps. But in the original ILM peeling, you have to actually indent the retinal tissue, the superficial retinal tissue, to create a friction. And so you can see that the amount of retinal tissue damage which can happen is more with the traditional IM forceps and is reduced by the laser edged shark skin surface. So the grasping force, as you can see here, the green bars, is significantly reduced if there is laser etching done compared to other coating of the external surface. So these are scans which are showing the different problems which can happen with ILM peeling. In some cases, you may create a secondary macular hole. There is dissociated optic nerve fiber layers. There is also shredding of the ILM, which happens in many of these cases. It breaks off. The ILM keeps breaking up during ILM peeling with the traditional forceps. And with the sharp skin forceps, again, there is less shredding of the ILM. And this is particularly useful, the shark skin forceps, in very difficult cases where you don't get a good grasp. Let's say there's a macular hole with retinal detachment, or a very high myope with myopic traction maculopathy, as Dr. Parolini showed, although she's a great proponent of macular buckle. But if you were to do vitrectomy with ILM peeling, the regular ILM forceps, you have to really pinch the superficial retina. Whereas in some of these cases, like if there is a detachment, there's no counter force. You try and pinch, the retina goes back. And instead of pinching any tissue, you realize that you're not holding anything. By the time you have closed the forceps, you're not holding anything. So especially in a detachment case where, let's say, a macular hole with detachment, once you go and try to indent the retinal tissue, you realize that it's not easy and there's nothing to hold by the time you close the forceps. So this is an example of a retinal detachment where I've attempted to peel the ILM. So this is a shark skin forceps, and it's not easy. By the time you try to indent, you push, you try to hold, the retina goes back. There's no counter force for the forceps to hold. But the shark skin forceps is able to hold better than the regular ILM forceps, the initial hold. But this is a very, very vertically detached retina. It's a bullous detachment. So I had to inject PFCL in this case. And under PFCL, again, it's not an easy case, but the shark skin forceps lets you hold or grasp the ILM, especially on the surface of the retinal tissue, very easily, very nicely, with a lot of confidence that you are not holding any other retinal tissue. This is another case where I'm using the hyper with 20,000 cuts per minute of Halcon. Again, a slightly difficult case where there is an epiretinal membrane as well. The initial break of the ILM was easy. There's an ERM on top as well. But then the surgery became a little bit tough. I had to inject triamcinolone to delineate the ERM and the ILM. But then these are cases where otherwise there is breakage of ILM. But in this case, as you can see, there is not much of shredding of the ILM. You can see the triamcinolone in some areas, but the ILM peeling has gone off smoothly in this case. But I would say the shark skin forceps is more useful in cases where there's no counter traction. For the indentation is not possible to hold the superficial layers or the ILM specifically. So I would say that in conclusion, ILM peeling is actually a series of steps. It's not just grasp and peel. Each step has to be carefully thought of. And in difficult cases, shark skin forceps with its laser-edged surface can help reduce the indentation force required to initiate the ILM peeling. Yeah, with that, thank you for your kind attention. Over to you, Professor.
Thank you, Dr. Aaron, for that wonderful talk and for nicely illustrating the use of new shark skin forceps. So one question for the lack of time, I wanted to ask that sometimes I wonder whether to do an ILM flap in this case or not. So what is your cutoff? Do you decide on OCT or you go by personal experience that whether to do this ILM flap in this case or not? So that for people like us who are new fellows, what would be the better approach to do and how? Dr. Aaron, can you please unmute yourself?
Oh, sorry. Yeah, sorry, I was muted. So, Prakhar, I just wanted to repeat the question. So you are asking whether we should do inverted ILM peeling in some certain cases, or what are my cases, what are my indications? Is that right?
Yes.
Yeah, so I do routinely in all cases. So earlier I used to do it only in large macular holes, but now I tend to do it in almost in every case actually. And I would say that most cases in our part of the world are actually large macular holes. You don't get to operate on 200 or 250 micron holes here. But yeah, so I do inverted ILM flap in all my cases.
And the last question, if I may ask, that in case of macular hole RD, would you like to peel it under the PFCL or just without the use of PFCL? What is your preference?
PFCL is good to have, especially if it's a bullous detachment. I like to have some counter force with which I can work on, because if you peel the ILM and the retina starts moving along with the ILM, instead of peeling, the retina moves. So it depends on how bullous it is. But in shallow detachments, I try even without PFCL. If it works out, that's fine. If it doesn't, then I go in for PFCL and peel it.
Okay. Thank you, Dr. Aaron. For the lack of time, we will go on to the next presentation. Thank you for that wonderful talk.
Thank you.
Thank you, Dr. Prakhar. So coming to the next session. So the session 2 in Hall A is What's Next? An Unrevealing Surgical Dilemma. It's my honor and privilege to introduce Dr. Hani Hamza, the professor of ophthalmology from Cairo University, Egypt, and a very well-known name in VR circles in India. He will be receiving the most prestigious VRSI or Vitreoretinal Society of India award of the Nataraja Pillai Oration Award. Welcome, Dr. Hani Hamza. Please take over the dais. Yeah. And the topic of presentation for Dr. Hamza is pearls and pitfalls in surgical management of advanced PVR. Welcome, sir.
Thank you very much, and thank you for inviting me to this meeting. And it's really my honor to receive this award from the Vitreoretinal Society of India this year. A real pleasure and honor. My talk today would be about pearls and pitfalls in the management of advanced PVR. And my talk would focus on two case scenarios, recurrent cases, and some special case presentations, as I'm going to show you. Well, what are the management principles in recurrent cases? Well, there are some basic principles that we have to follow while doing recurrent cases with PVR. First of all, if the patient is phakic, then we remove the lens. Why? First of all, to improve your visibility, as many of these cases may have cataract that have resulted from the previous surgery, and as well to gain better access to the area of the vitreous space to allow better shading of the vitreous in this very important part of the eye. In my hand, if the eye is silicone filled, usually I remove the oil completely and work in a fluid-filled eye. I don't like working in an eye with two different fluids inside the eye and different refractive indices that may impair your visibility and make your maneuvers more difficult. So with the exception of very simple recurrent cases in which I know I'm going to remove a single membrane, do a small retinotomy and vein, these cases I can do under silicone oil, but in most of the cases, I remove the oil and work in a fluid-filled eye. Then I start to revise previous surgery pitfalls. What went wrong? I look for hyaloid remnants that may have been overlooked or omitted, and incomplete vitreous shading in the periphery, which is a very important cause of retinal shortening and anterior PVR. We have to look for the retinal breaks, which is the main cause of recurrence or the only source of recurrence, and release traction on these breaks and do laser and seal them. And finally, if you have retinal shortening, which is also quite common in these cases, go ahead, do a retinotomy and retinectomy, and be generous in these cases while doing them, as overdoing a retinectomy is much better than underdoing it and leaving residual traction. Dealing with PVR, I start by removing the ILM and the posterior component of the PVR and move from posterior to anterior to deal with the anterior part by dissection or retinotomy or retinectomy. And then you deal with significant subretinal proliferation. Either you remove it completely or simply just segment it. And it is noteworthy to say that not all subretinal proliferations need to be removed. Some of them are harmless, so better leave them in place if they are not preventing the retina from being reattached. Then you do it endolaser, in many cases 360 degrees, and refill with oil. Now let us start with this first case. This case was silicone filled, so I removed the silicone oil. You can see the bubble on the right side, the residual bubble that is hanging anteriorly. And I start peeling the posterior membrane. I elevate the edge with a Thanos scraper, and then you grasp these membranes and remove them. In many of these cases, while you remove the membranes, parts of the ILM and even large parts of the ILM also are removed, as we are going to see while I'm staining later in a moment. Now, I'm introducing the dye, and you can see that parts of the ILM have been removed in the posterior pole, and all I have to do is to widen this ILM peel. Now, I'm looking for the break in the periphery, which is the cause of recurrence, and release the traction, the anterior, especially the anterior part of the traction of the break, by excising it with the occutome, complete the fill with perfluorocarbon, and do the endolaser, and in this case, I did a 360 degrees endolaser. Now, this shows you the punishment if you don't remove the ILM in a high-risk case of retinal detachment. This was a case of a giant retinal break. And although the retina is reattached, but at the time of silicone oil removal, you have this PVR. PVR does not mean that the retina must be detached. Sometimes the retina is attached. And having this macular pucker or this tough membrane in the posterior pole significantly compromises the visual acuity, the final visual acuity of these cases. Therefore, in cases of PVR, I do recommend removing the internal limiting membrane simply to avoid this complication, which can dramatically reduce the post-operative final vision. Now, this is the contrary. In this case, I removed the ILM in the first surgery, and this is the recurrence. The recurrence respected the ILM peel, as you can see. It's only at the arcades and in the posterior pole where I have removed the internal limiting membrane, there is no PVR or epiretinal membranes. Although the membranes are very tough, similar to those of diabetics, and I had to use the scissor to remove them. This was the only eye of this patient. But being patient and moving slowly, with blunt and sharp dissection, I could remove these membranes and reattach the retina again. I did a small retinotomy to drain the subretinal fluid after injecting the perfluorocarbon. And finally, I reattached, this is the retinotomy, doing a fluid air exchange, endolaser reattaching the retina, as you can see, and finally endolaser over this small retinotomy and 360 degrees and refilling with silicone oil. Now, this is a one-eyed patient. He presented initially to me with a simple inferior recurrent detachment after having a vitrectomy elsewhere. He vanished for 2 weeks and came with this picture: subretinal silicone oil, massive anterior traction that actually pushed the retina anteriorly and pushed the silicone oil under the retina. In such cases, the first thing to do was to open the funnel by injecting some perfluorocarbon, and you have to do a generous 360 degrees actually retinectomy and retinotomy to release this traction and to be able to remove the subretinal silicone oil, as you can see. One of the problems in these cases is that whenever you get a bubble of silicone oil floating anteriorly, it impedes your visualization and you have to stop and remove it and then continue the procedure. You can see as you do this anterior retinectomy and retinotomy, the retina relaxes posteriorly, folds back, and you have some radial folds that I do a radial retinotomy even to reattach them. And the retina was finally attached in place after doing the 360 degrees endolaser. Now, I'm bringing you this case. This is a boy with Stickler syndrome. And the initial surgery, this is the initial surgery. He had a very atheral posterior hyaloid. And I can show you that I removed the internal limiting membrane over the macula. Now, after 4 weeks, and he is silicone filled, this is the picture. Massive recurrent PVR with tractional holes and a tractional macular hole because the ILM has been peeled. And this has already been mentioned that sometimes the removal of the ILM can create macular holes by my colleague previously. And in this case, since I have no ILM, I had to do an autologous graft to close this macular hole and finally do a direct PFC silicone oil exchange, and the retina was reattached at the end of surgery. Now I'm going to show you some special situations also as well. This is a girl with Stickler syndrome. In these cases, actually, the posterior hyaloid has an abnormal insertion into the retina all through, from the posterior fold up to the ora serrata anteriorly. And you have to be very patient and use a bimanual technique in order to be able to peel the posterior hyaloid in these cases. Additionally, there is a subretinal fibrous band. You can remove it through a small retinotomy. It was not removed completely, but it released the traction on the retina and allowed the retina to fall back. Now you have to move anteriorly and do shading of the vitreous plates very meticulously in order to complete the procedure. Now, this is another interesting case, a patient with a giant plaque and choroidal detachment. And initially, whenever I put the infusion cannula anywhere in the eye, I could not visualize the tip of the cannula inside the eye. So I decided to go in and see what's going on inside the eye because of the choroidal detachment. You can see a turbid vitreous and a folded flap of the giant retinal plaque. So I decided to remove the lens. And after removing the lens, put an anterior chamber maintainer to be on the safe side and go inside the eye and see what's going on. So this is the picture, and you can see the folds of the choroidal detachment. And injecting some perfluorocarbon in the posterior fold, I recognized that there is a tough subretinal band 360 degrees around the retina moving. So I used the spaghetti technique by hanging one edge of this fibrous band to the forceps and rotating it around its own axis to pull it out of the eye. You can see how long it is. It moved 360 degrees around the retina, and this is why the retina was pulled anteriorly and I could not put an infusion cannula. After removing this subretinal fibrous band, you complete your vitrectomy. This is an area where I created an iatrogenic break when I tried to put the infusion cannula initially, and the rest of the surgery is the same. You remove the internal limiting membrane because it's a high-risk case, and do your endo laser as in any other case. This is the final case I'm going to present, and this is a patient after a mine explosion with a neglected intraocular foreign body, and this is his only eye. The retina is pulled actually at the site of the foreign body where it is incarcerated in the area of the ciliary body. This is the back surface of the retina, by the way. So you go in and you cut the retina from the point of incarceration and let it fall back posteriorly. After doing that, I located the foreign body in the area of the ciliary body. So I went in with the forceps and took it using this iris shelf technique out. And then you go in again after removing this foreign body to deal with the rest of the PVR in the posterior fold. Now I am injecting perfluorocarbon in order to open the planes and identify the membranes. And under perfluorocarbon, you stain the internal limiting membrane and start peeling the membrane under perfluorocarbon. When you peel under perfluorocarbon, you have to be more tangential, because if you pull the ILM vertically, it cuts away and fragments and shreds, which makes things more difficult. After removing the internal limiting membrane, you remove the remaining fibrotic retina that you cannot reattach by any means and leave the posterior retina attached, do your endo laser, and so on. One of the points is that when you have massive anterior PVR that cannot be dissected, don't waste time in dissecting the retina, and you know you're going to do a generous retinotomy, transverse retinotomy, to release the retina at the end. And thank you very much.
Thank you, Dr. Hani, for a very fantastic detailed presentation about all the PVR peelings. So two of my queries out of the whole presentation. One, what would be your indication for ILM peeling? You have already suggested if it's a high risk case, what would be a take home? So like, what is an high risk case for you? That is one. And is there any role of implanting an IOL in the cases of such advanced PVR? Any take on that by you?
Yes, for the first question, I mean, high risk cases are cases with large retinal dates, multiple retinal dates, pigment dispersion in the vitreous. You have such a turbid vitreous, eyes with ocular hypotony and choroidal detachment, eyes with vitreous hemorrhage, giant retinal dates, and traumatic cases as well. I consider them as high-risk cases for PVR, especially those with penetrating trauma and areas of posterior perforation. So all of these cases do a primary ILM peeling. I think over the years, we have noticed that if you have a retinal detachment and the macula is reattached in the first surgery and you get a reasonably good vision, then you get a second hit by a recurrent detachment, then the vision falls profoundly. It does not recover back. So I think try as much as possible to avoid macular pucker and the recurrent detachment. This is for the first question. So these are all high-risk cases and all in which you have to do ILM peeling. Now to the second question was, can I recall it again? Was it?
So whether do you consider placement of intraocular lens in cases of such advanced PVR?
Oh, yes. Well, actually, this is, I mean, in pediatric cases, I avoid putting an intraocular lens because these cases usually, the IOL fibrosis, you get a PCO, and at the end of the case, you cannot visualize the retina properly. If you need to reoperate, you cannot do it. In adults, yes, I can consider, but not in extreme traumatic cases as I have shown you. My first priority is to reattach the retina. Even if the patient is aphakic, I can manage and put a lens later after removal of silicone oil, and I feel that things are safe in this eye.
Thank you. Thank you very much, sir. It was very helpful for all the kind and salient points which you have highlighted on your first and second slide very beautifully. Yeah. So, Dr. Neha, you can take over from now.
Do we have
thank you,
time for one quick question? This is Dr. Ridhima.
Sure, ma'am.
My pleasure.
Yeah, good evening, sir. So when you see a lot of subretinal bands, removing these bands would mean, creating one more retinotomy, an additional retinotomy. So how do you approach such cases with extensive subretinal bands? Do you want to create one large retinotomy and access all the bands through that? Because then, recurrences are, it's a huge risk with such cases.
Well, this is a real problem. I mean, if you have a single subretinal band, you can do a small retinotomy, remove it, or segment it. But with extensive bands, yes, you do have to do a large retinotomy, maybe invert the retina and remove the subretinal bands. The problem is that by doing this, sometimes we create a vicious circle of PVR, because cutting the retina by itself can incite the PVR and expose the RPE cells to proliferate. So when I do this, I use also post-operative methotrexate injections and to minimize recurrence in these cases. But in all cases, I remove only the subretinal bands that are necessary to be removed. Any bands that do not hinder the retina from being reattached are left in place.
Thank you so much, sir.
Thank you.
Good evening all. So it's my pleasure introducing our next speaker, Dr. Vishal Rawal. And he is currently working as consultant at L.V. Prasad Eye Institute, Hyderabad. And besides being a diligent clinician, he is also a great academician with was published widely in various peer-reviewed journals. And his main interest is in oncology, is retinoblastoma. So over to you, sir, and looking forward to your great talk on Coats disease.
Thank you. Thank you, Nia, for the kind introduction. Somehow I'm not able to switch on my camera. Please pardon me for that. Let me share my screen.
We'll miss seeing you.
Yes. Can you see my screen?
Yes, sir. You can.
Okay. Thank you. So first of all, I'm thanking the organizers for giving me this opportunity. The topic which was allotted to me was something challenging, and looking at all the previous presentations, I think my talk would be very simple and lucid, but I understand the context of the disease, particularly in children, which we see Coats disease. So this might be helpful for the fellows and the residents. So, okay, they asked me to start my video also. Okay, got it. So I have no financial disclosure. So as we all know, just a brief introduction about Coats disease. We all know it is a rare idiopathic retinal exudative vasculopathy. And from our in-house publication, what we did a couple of years back, looking at the in-house patients who have diagnosed to have Coats disease, close to around 675 patients in 690 eyes, we came to know about the prevalence of this rare idiopathic exudative retinal vasculopathy disease titled Coats disease, and the prevalence was 0.025%. So even though it is rare, but in Indian context or in a hospital-based population study, we could see the number is still very high. And this was over 10 years data where we could see close to around 600 patients. Classification, as we all know, which was proposed by Shields, and looking at the results, what we could found in our study, we could see the patients who had stage 3 and higher stage Coats disease was close to around 1/3, 20, 10, and 1. So it is close to around 30 to 33%. So in all essence, this means that even though the disease is rare, but the presentation, particularly stage 3 and higher, where we usually see foveal or extrafoveal exudative retinal detachment, and in some cases end stage disease, particularly with neovascular glaucoma, phthisis, and vitreous hemorrhage, we know this disease has a burden, particularly the children. Other important factor what we could find out in our study was younger the age, severe the disease. So this is very, very important, because usually the patients who presented within the first 5 years of age had a very severe disease as compared to patients who presented after 10 years of age. So this was statistically also significant in terms of staging of the disease. As we all know, stage 3 and higher, usually you see the patients presenting with, or children presenting with, white reflex or leukocoria. And the most common differential diagnosis which you want to rule out in a particular child at this age group is retinoblastoma. But Coats does have its classical clinical features, which you usually will see presence of exudative retinal detachment with multiple subretinal yellowish exudation, which is characteristic, made up of cholesterol or lipids. And as the age advances, you might see this exudative detachment lying completely behind the lens, along with vitreous hemorrhage and multiple retinal telangiectatic vessels. In stage 5, you might see child might be having end stage disease with neovascular glaucoma, ectropion UVA, vitreous hemorrhage, and the patient might have present with a painful blind eye. If left untreated, these children usually in close to around 8% of cases in our study, we could see were diagnosed to have neovascular glaucoma. And at this age, less than 5 years of age, if left untreated, a child developing a neovascular glaucoma, painful blind eye, and ultimately leading to enucleation, I think it is detrimental. So as a clinician, it is very, very important to not only diagnose the disease at early stage, but to do treatment in that perspective that in spite of not giving vision to the patient, but at least you are preventing long-term sequelae such as neovascularization of iris or neovascular glaucoma. So with that understanding, I'm going to show you 2 important techniques, how the external SRF drainage is done in a child with stage 3 or higher exudative retinal detachment. So you could see in this child, there was total exudative retinal detachment with retina lying completely behind the lens. In a standard technique, what we do is 360 degrees peritomy followed by tagging of all the 4 muscles. And then you do a lamellar scleral dissection as we do for any fragmentous retinal detachment. You separate the scleral fibers, prolapse the choroidal knuckle, and with a sharp 26 gauge needle, you puncture the choroid and let the subretinal fluid escape. With this technique, all over the last 1.5 decade, I was doing this kind of technique for external SRF drainage, and it worked beautifully. The child, usually you see the retinal detachments kind of settling, and the issue was, the results were great. However, the important point, I think, which needs to be stressed, because of the severe hypertony, the child usually might have an anterior chamber hyphema, as was seen in this picture. And because to form the intraocular pressure, we need to inject BSS or BSS plus fluid. So with that understanding, I had a talk with Dr. Mahesh Shanmugam, I think a couple of months back, and he shared his technique of doing external SRF drainage, not only for Coats disease, but for any other exudative attachment, particularly secondary to any intraocular tumors also. So this is a case, what I want to share. This is a child, 2 years old, presented with right eye, severe neovascularization of iris with 360 degrees ectropion UVA, with presence of total exudative retinal detachment, as you could see, which was seen lying completely behind the clear lens. And the intraocular pressure in this child was 59 millimeters of mercury. There was only perception of light without any projection of rays. Taking into consideration, explaining to the parents and doing the counseling that the rationale of doing the treatment was only to make sure that the child ultimately doesn't undergo enucleation. And once the consent was taken, parents agreed for an surgical intervention, which was done for this child. So this child was subjected to external SRF drainage with anterior retinal cryopexy with intravitreal bevacizumab injection. So this is the video what I want to share. In this, as you can see, there is a total exudative detachment seen behind the lens. And what we do in this technique is very, very simple in and out technique. We just put a small AC maintainer as we do for any other case. So the purpose or the rationale of putting the AC maintainer is to make sure that the globe doesn't go into hypertony at any stage when you are doing the external SRF drainage, was for seen in classical external SRF drainage technique. Second, you need to use the same 26 gauge needle without the plunger, and the bevel not facing the retina, but exactly 180 degrees opposite. And once you raise the bottle height and the fluid starts egressing from the anterior chamber to the posterior chamber, you will see the SRF starts draining into your syringe hub. And this way you are seeing the maneuver of removing the SRF drainage, which is very, very controlled, and it you will see in front of your eyes the retinal kind of going back or settling, and with time close to around 1.5 to 2 ml of fluid you can easily remove. Important points what I want to highlight: you need to put the needle as back as possible, to choose a quadrant which has the maximum bullous exudative attachment. And as you can see, after removing 1 to 1.5 ml, the retina has gone back. And once you do indirect ophthalmoscopy, you might be able to even see the optic disc and the retinal vessels. And that will help you to do the further adjunct treatments such as cryotherapy to retinal telangiectatic vessels, particularly in the periphery, and supplement it with the intravitreal bevacizumab injection. I understand this is not a one-time treatment, but I think this is the best what we can offer for a particular child who has stage 4 or higher advanced stage Coats disease. Post-op, you could see this child has a settling exudative attachment with multiple telangiectatic vessels with massive subretinal exudation. And at 1 month, you could see the optic disc, you could make out the retinal vessels, you could see the subretinal exudation, and the fluid has kind of dissolved. So why we want to choose a newer technique as compared to the standard technique what we have been using for last 1 decade? The needling technique, what I understand, is very, very simple. We don't need to do extensive surgery as we used to do previously, like conjunctival peritomy, extraocular muscles tagging. The important advantage of using this technique is to prevent anterior chamber hypotonia and hyphema, which I used to usually see in many of my child, particularly at day 1 and 1 week. Surgical time, again, it is very, very less. Learning curve is very less, and the patient recovery is very fast. And this technique is very reproducible. It can be again attempted within 2 to 3 weeks if you see the subretinal fluid or the exudative fluid has come back again. The message what I want to pass on to all the colleagues here is this technique is just not limited to Coats disease, but any exudative retinal attachment where you feel where the retina is kind of lying way behind in the lens, and you can make out the quadrant which has the bullous component. Just putting a needle and putting AC maintenance should help you to reduce the extent of the bullous exudative attachment and do necessary treatment. And this works beautifully even in cases of intraocular tumors, especially choroidal hemangiomas, where they are associated with exudative attachment, and even bullous exudative attachment secondary to chronic central serous choroidiopathy. So with that, I will stop my presentation and will be happy to take any questions.
Thank you, Dr. Vishal, for such a
Hi,
nice talk.
can I have a question, please?
Please go ahead.
Sure.
Yeah. This is Dr. Abdullah from Yemen. I'm LVBI alumni 2014. I need to ask Dr. Vishal one questions regarding this very nice presentation.
Yes, sir.
Yes, Dr. Vishal. Regarding taking the subretinal fluid outside, what your thoughts to go in the internal drainage, like we are going to do internal vitrectomies?
Yes.
Like doing internal drainage. What your thought process regarding doing for these cases of like Coats disease, for example, doing internal drainage immediately after doing this external drainage, go for external drainage for the remaining of the fluid, and then do routine surgery of BBVs and silicone oil injection, and do aggressive laser all around telangiectasia.
Thank you. Thank you for the question, sir. So as you understand, all these children, they have exudative attachment. There is no rec component. And second thing, you will see in all these children, usually they will never present with the proliferative vitreoretinopathy or vitreous disease, as you will see any other pediatric retinal attachments. So the internal component, as we see, the vitreous is always clear. There is no PVR component, and there is no rec component. So in that context, I think the primary line of treatment or the standard of care should be always to do an external SRF drainage. However, in few cases, if you feel the fluid is not going back for whatever reason, I think just doing a simple vitrectomy and not to create any break or putting an oil, particularly in child 2 years, 3 years old, it should be very detrimental. So I would resort to doing external SRF drainage as the primary mode of treatment. and doing vitrectomy and putting oil, I would suggest should not be a good option, particularly in child who is 2 to 3 years old and who doesn't have a direct component at the start. And last thing about the SRF drainage, we are now doing kind of basic science research, particularly to understand why in a child less than 5 years they present with this severe form of disease as compared to adult onset coat disease, which usually presents with only stage 1 or stage 2. And we are doing some lipodomic assays on this subretinal fluid to understand the lipid content and whether any role of inflammation plays in the pathogenesis of Coats disease. So I hope in the near future, we should be able to give further insights into pathogenesis of Coats disease and solve the mystery of younger patients presenting with severe Coats disease.
Yes, thanks, Dr.
Dr.
Vishal, for
Vishal,
this.
one question from me. This is Dr. Ridhima. Any advantage of combining this with chandelier assisted? Would it be more controlled if you use a chandelier assisted external drainage?
So I usually do under microscope only, because the retina is kind of in your view and you want to see that it is going down. Now with the people kind of familiar with chandelier, if you feel the retina has gone kind of particularly more than 50% back, you can put in chandelier. It should not be an issue. You can use a biome and see where you want to do the cryo under visualization. But I think I am from the old school of thought. I usually use indirect and then do 360 degrees cryo. So I think it works either, provided the exudative component has kind of gone more than 50 to 70% back, so that you are not kind of putting the chandelier into the subretinal space.
Yeah, my question was similar to Ridhima only actually, that how do you judge that how much amount of retina has gone flat and now the effect of cryo is gonna come? So that's through the microscope itself.
So once you remove the fluid 1.5 to 2 ml, you know the volume of the vitreous cavity is kind of 2 ml. So if you remove 1.5 to 2 ml, I think it is inevitably 70 to 80% of fluid is kind of removed. Posterior pole, because your needle is not close to the posterior pole, you are kind of might be in and around the arcade. The needle hub is in and around the arcade. So around 70% of fluid you should be able to remove. And the rationale is to do cryo to the periphery. I think there where the whole retinal telangiectatic vessels are lying, not at the posterior pole. So if you could do cryo, I think your aim of treatment is achieved.
What distance do you choose from the limbus to introduce the needle in the needling technique?
So close to around 10 to 12 millimeters.
Thank you, Dr. Vishal, for talking about Coats disease, which is actually very rare with us.
Doctor, I have one small question, please.
Yes, please.
Dr. Vishal, sorry for that. Regarding learning curve, I think learning curve of this technique is a bit difficult because of this anterior chamber maintainer control is very difficult for the beginners, because he will touch the anterior capsule of the lens and you will go for other pathology.
I little bit disagree. I think we are all vitreoretinal surgeons, and I think we should be able to put a maintainer right above the surface of the iris. And I think inadvertently, even if it touch, I think it is not a great issue. You can kind of do a secondary cataract extraction.
Because it is really, as an idea, is very great, but for the beginner it is not good, because he will touch the anterior capsule definitely in the first and second time. At least I think that.
Sorry to disturb, but we are running late, so thank you.
Yeah, I understand. Thank you.
Okay. Thank you. Thanks.
Yeah, go ahead.
Hello everyone, I'm Dr. Sankeet. So I'll be inviting Dr. Abdullah. So Dr. Abdullah's specialization in surgical retina as well as in ocular oncology. He has over 11 years of experiences, and especially is working in Soliman Fakir Medical Center with a lot of laurels and lot of achievements. I would not waste much time, and I would let Dr. Abdullah take over the show. Thank you, sir.
Thank you very much, dear. And for the correction, I'm working in King Abdulaziz Medical City and King Saud bin Abdulaziz University for Health Science, and Siman Faqih is my private section. So we will start sharing, and my talk is going to be about application of vitrectomy in ocular oncology. Hopefully you can see the slide properly, and pardon me for the voice because I'm speaking during my travels. Through my travel, so there is sometimes a background sound we cannot control. So I think.
Yeah, your slides are visible, doctor.
Yeah, so the vitrectomy is become safer with the higher cut and good control of IOP, and faster with sutureless, and easier with the small port size and sharper trocars, so avoid the leakage. And this is why it's become more applicable for many diseases like CRVO, BRVO, diabetic macular edema, ocular oncology is just one of them. And the first part of the application is the diagnostic. And this is very important in lymphoma, for say as it is one of the diagnostic tools. It's a normal 3-port pass planotomy. And how we do it is we keep the infusion closed, because we need to get a very concentrated material, and to be able to centrifuge it to make it more concentrated and increase the chance of having found the malignant cell. The specimen should be immediately delivered to the cytopathological labs, and to get a good result, they have to be aware that you are going to send them the specimen. This is a very precious specimen. It came from inside the eye, and it's not like any other tumor in the skin or other place that you can take it second time. So the cytology for the vitreous sample is very important. As you know, undiluted vitreous is prepared for the cytology, and maybe we can use the diluted one for culture later on. So culture and PCR could be used for the remnant of the specimen. And the idea is to have 100 microliter of undiluted, which should be submitted for cytokine analysis, in which IL-10, IL-6 ratio is very important to differentiate between the inflammatory process and the malignant cells. Clonality is very important, in which we can precise the cells that has been repeated and the source of the lymphoma itself. So the syringe, you can use whatever you like, depending on the type of the vitrectomy that you are using, and 5 in most of the time is recommended. So this is my assistant, and she's withdrawing while I'm keeping the center, the tip of the vitrectomy inside the center. And whenever we 1 ml, she stopped withdrawing, and we send it for cytology, and we after that continue the vitrectomy. For more details about this procedure, this is one of our publication of that, which has been published in 2014, and you can go back and see further information and the technique itself, the steps and the parameters. The second part is about the treatment, in which vitrectomy could be a treatment for some types of disease like the melanoma, in which we do endoresection. And this is mainly to prevent neovascular glaucoma in radiated eye melanoma. It doesn't improve the vision, but it prevents complication, and it saves the eye cosmetically. And there is an indication for that. It's not every melanoma is fit for endoresection. The tumor diameter should be more than 10 millimeter to justify this type of procedure, and the tumor should be less than 15 millimeter, because more than 15 millimeter is an indication for enucleation. Thickness should be more than 5 millimeter, so you have enough amount of ischemic cells after the radiation that indicate the endoresection. Should be after the treatment by radiotherapy. And I know that this is controversial, but we always like the eye to be radiated before to decrease any risk of dissemination. So this is one of the our case in which you dip the vitrectomy tip inside the tumor and try to eat it. And this is the mushroom type. This is the classical type of it. Most of the complication is a bleeding, and you can control it by either increase the IOP, but you have to be careful. Increasing the IOP much can opaque the cornea and cause corneal edema. So you have to be careful during this procedure. I always prefer the 23 gauge and not less than this one, because smaller than that will be very difficult to suck the material through a small gauge tube. You keep eating till you reach the sclera, which is the whitish color, and you will get the right reflex. And this is the target for you when you are eating the tumor cells. And as you see here, you have to have a high vacuum power and have a low cutting rate to be capable to eat all the material. And sometimes if you have a remnant of the material, you can do laser it, especially if you find it infiltrating in the sclera. And you can do a further step even after radiation by do laser burning of those infiltrating through the sclera. As you see here, so we reach it, the sclera, we try to eat, and sometimes you cannot remove it, so you have to scratch it with the tip. And as I said, you can use the laser to burn the blackish material inside the sclera itself, which is the infiltrating tumor, and also around the retinectomy to flatten the eye. After that, you fill the eye with silicone and usually remove after 3 months. So this is the eye, and this is the first case. This is one of the publications. It shows you that the severest complication that usually lead to secondary inflammation is neovascular glaucoma, and this is why the endoresection is indicated. It's indicated to keep the eye cosmetically because the neovascular glaucoma is represent around 80% of the cause of enucleation post radiation. It's as we said, it's 82% reduction of the risk of developing neovascular glaucoma because you are getting rid of this big ischemic mass, which the anti-VEGF is not enough to save it, even after the radiation. 25 gauge is used also as a biopsy, and this is very helpful. And the retinal biopsy we'd like to show you here. Sometimes with a small gauge you cannot get enough biopsy, so you may need to grasp it with a forceps and do retinectomy to remove it. And in this case, you do a vertical Caesar after the laser around the area that you want to take it. And this is a suspicious lesion. After you take it through forceps, sometimes if the specimen is big, you have to remove the trocar at the same time you are pulling the forceps to be able to pull it out from the eye. But even though sometimes it's not really enough, and this is where it should be increasing the sclerotomy by 18 gauge to make it more bigger, because the size of the specimen is the most demanding by the cytopathology. Cytopathology doesn't like a small specimen, and if the lab is not familiar with dealing with the small specimen, always you will end up by missing diagnosis, closing the eye and finishing the case. I think this is my part, and it's always a pleasure to be a part of this meeting. Thank you very much.
Of surgical videos. Can we ask the panel if we have any questions for Abdullah?
Can you repeat the question, because I didn't hear? I think there is an issue with the connection. Hopefully it was not interrupted.
I ask you, so while doing endoresection of the tumor, therapy or from the center, which is while doing the endoresection of the tumor,
yes,
you like to start from the pillar, while doing that or from the center?
You do it from the center always, because actually it's a mushroom type, so you don't know exactly the retina, where is it under it, so you keep in the center to eat slowly till you found the size of the stalk or the size of the base of the mushroom types. Then you start building your continuation, building on that, because you cannot see the beginning of the retina under the mushroom type. It's like an umbrella.
Yeah. So commonly we surgery this having a exudative retinal detachment. So how long would you before vitrectomy?
This is very good. Actually, this is a very good question. There is a lot of tumor in the choroid or in the retina associated with the exudative retinal detachment, but this is not your problem because after radiation, usually it disappears, especially with the steroid, it disappears. So it shouldn't be a problem on that. The idea is when to operate after radiation. Most of the times they give the patient 3 months after radiation to be able, but not more than that. So you can have a good timing for surgery.
Thank you, Dr. Abdullah. I think we'll head for the next case.
Thank you.
Thank you very much. Thank you.
Hello, everyone. Hello, everyone. The next speaker is Dr. Mohammad Tawfiq. He's a vitreoretina consultant and lecturer of ophthalmology in Giza Memorial Institute of Ophthalmology Research. Over to you, Dr. Mohammed.
Good evening, everyone. You can see my presentation now?
Yes, we can see it.
Yes, so my presentations will be in short, just to demonstrate a case of joint retinal tear and how can we approach the joint retinal tear. First, I will present a straightforward joint retinal tear and what I'm doing in such a cases by doing a curve vitrectomy, removing the vitreous all around, and starting after removing the vitreous to unfolding the detached and folded retina to check the status of the tear and how extended is it. And also starting by assessment to how it's the tear is tense. So if you have a circumferential contraction or something like this, before I'm putting the PFCL, I put this I do what called radial retinectomy to relaxing the horn and detach the detached retina from attached retina. And by putting the PFCL, I completely flattening the retina. And now, as you can see, the radial cut that I'm doing separates the detached retina totally from the horn. And so now we don't have the availability or of retinal slippage. And in this case, I put just SF6. I didn't put the silicone, and the post-operative, the retina with the flat, and the patient's visual acuity is good. I will present another type of a giant retinal tear with a lot of star folds and an old standing giant retinal tear. And this case is done by my fellow, and it's already going a step-by-step approach, removing the vitreous and also removing the anterior flap of the retina, assess the status of the flap of the detached retina, put the PFCL, and complete removing the peripheral vitreous. Now we're staining the macula with the brilliant blue under the PFCL and check the periphery of the retina for the vitreous shaving while the PFC is there, establishing or fixating the posterior pool. Starting ILM peeling in such a case because we are fearing of an epiretinal membrane proliferation after that, and also to be sure that we're removing all the epiretinal membranes and posterior hyaloid. So in such a long-standing giant retinal tear, we are usually approaching the ILM and remove it. If it's a fresh RD or fresh retinal giant retinal attachment, we are not usually removing the ILM. And after removing the ILM, and complete peeling of the ILM underneath the PFCL, and believe me, it's a good idea. I do also the radial cut. In such a cases, I do the radial cut using the cutter, also to complete separating the detached retina from the attached retina, relaxing the peripheral retina. Also, we do the shaving for the anterior edge of the giant retinal tear to relax the folded retina and to prevent the occurrence of slippage and occurrence of the recurrence from this area. Complete separation of the periphery of the retina, and also do the perfect laser and sealing the peripheral breaks. And as you can see, everything is doing perfect, fluid air exchange, and we put that silicone oil at the end of the surgery. But what we are not expected in this case, that the retina, the giant retinal tear is still giant. And this is what we are seeing. And this is what we are seeing 1 month post-operative, the giant retinal tear become giant again underneath the silicone with developing of a severe PVR. While we are revising the surgery, the first surgery, we didn't feel that we have missing something for moving the ILM, for complete removing of the vitreous. And we starting to deal with such a case. First message for me in such a situation, don't peel the epiretinal membranes and relaxing the membranes from the surface of the retina after removing the silicone. Keep the silicone as a tamponading, supporting the retina, and starting to peel the epiretinal proliferations and PVR before removing the silicone. Believe me, if you decide to do it after removing of the silicone, the retina will, the mission will be more difficult. As you can see, I keep the silicone in the place and starting removing the peripheral and anterior PVRs, starting to relaxing the surface of the retina and searching as much as I can for the membranes by also using the two forceps, relaxing any type of membrane. As you can see now, I'm using the two forceps by tangential movement. By these two forceps, I'm moving the membranes. And while I feeling that the membrane is removing, I now starting to feel that retina has become more relaxed. So my first message in such a situations of the BVR and rolled edges, don't remove the silicone before you're removing as much as you can the periphery or the BVR. And you can see when I removing the BVR and as I can complete peeling of the epiretinal perforations, you can see the fold is open. Now I decided to remove the silicone oil and go inside and put the PFCL to flatten the membrane, the retina. While we are putting the PFCL, as you can see, now I do the relaxing peripheral retinectomy. So I feel that there is a circumferential contractions between the retina and the horn. So I completed to 20-70-degree retinectomy to feel that to relax the retina as much as I can horizontally. And while I'm flattening the posterior pole and checking the posterior pole, I feel that there is something behind the retina. I suggest that is a PFCL. So I aspirate the PFCL inside the retina, keep it in the syringe, and just flip the retina. And I see the bubble of PFCL underneath the retina. I remove it, and again I inject the same PFCL. So I remove the PFCL in the syringe and deal with the subretinal PFC, and then put the same PFC again and flatten the posterior pole of the retina and do the laser. So before you're going out at such a PVR and circumferential contraction, check the retinal status of the subretinal state if you have a missing subretinal PFC. And this was the post-operative, the patient have the visual acuity of 0.1. So my conclusion in such a situation, the regular cases of giant retinal tear, you hear me, huh? The regular cases of giant retinal tear, you can do it without putting the silicone. But if you have a BVR case or long-standing giant retinal tear, we usually peel all the surface membrane, even the ILM, and put the silicone oil. But not all the straightforward cases, or not all our usual cases is going like this. As you can see, we have the giant retinal tear just 1 month post-operative. It's keep giant, and the BVR was so aggressive. The message here, if you have such a situation underneath the silicone, try to do the job before removing the silicone, because if you are in the fluid field, the job will be more difficult. Before we leaving the eye, check the circumferential contractions if you need to do a more degree of relaxing the circumferential contraction, and also check the subretinal status if you have a missing subretinal PFCL. Also, you can aspirate the same PFCL and put the same PFCL again, so you don't need to change the PFCL. And this is my message in such a cases. And thank you.
Excellent cases, Dr. Mohammad Tawfiq. Sir, I would like to know your experience or development of post-operative PVR in cases with formation of those relaxing retinectomies, radial retinectomies, with or without it? Because there's a lot of bleeding happening while doing these relaxing incisions. So any difference in the PVR, post-op PVR formation?
When I decided to do the radial relaxing retinectomy, separating the giant retinal tear from the attached retina in the horn, I didn't feel any problem about the PVR. But my feeling in such a 2 radial retinectomy is helping me to do a fluid air exchange and put the silicone, not doing a direct PFC silicone exchange. Because for me, the slippage occur from circumferential contraction, not from anteroposterior contraction. So when the giant retinal tear is still connecting to the horn, the slippage occur. If you separate the giant retinal tear from the horn, the slippage will not occur. So it's not related to post-operative PVR. It's related to the maneuver inside the surgery where you need to go through direct fluid air exchange or something like this.
So one more question about GRTs. The main problem occurs when there are the folding of the edges, especially when RD is pretty chronic. So what's your take? You cut it or you try to unfold them using some instrument, be it a forceps or a...
If we have a chronic status with a PVR, I use a 2 forceps to relax the anterior edge of the giant retinal tear. If we have a surface PVR over it, if it is rolled without a surface PVR, I cut it. If it is just a PVR over the surface, I remove it. But if it's just a roll, I cut at the edge and didn't try to peel it. I remove it.
Nice talk, sir. I have one question. Yeah. This is Abdullah. If you have time, I have one question for Dr. Mohammed.
Go ahead, sir.
Oh, yeah. Can I ask you, Mohammed?
Dr. Hanson, how are you?
Fine, thanks. Great case. You know, I want to ask you an opinion. I tried both ways. I removed first the silicone oil, and then I would put PFC back in, and then I like managing, these PVR cases with PFC, because the retina gets more stable when the surface tension, the interfacial tension from this perfluorocarbon liquid is better to push the retina down. So oftentimes I do as you did with the silicone oil and trying to get the membranes and separate them with the silicone oil. But sometimes it gets a little hazy because some fluid is coming in to stabilize the posterior chamber. So have you tried with perfluorocarbon instead?
Yes, I first, in such a PVR cases, I try to use the PFC area, but I fear of going the PFC inside, underneath the retina, and the hazard of to search for the bubble. Where is the bubble? As you can see, I do this job without PFC, and at last we have a PFC bubble underneath the retina. And you can thinking about if you are doing all this job with the PFCL and pulling something like this, so we will definitely have a PFCL underneath the retina missing. So the problem for the PFCL is the missing PFCL underneath the retina that you didn't expect while you are doing the surgery. I totally agree with you that the surgery underneath the PFCL is much easier and much controllable than the surgery while you are keeping the eye on silicone oil. But for me, it's like the traction retina detachment diabetic. I didn't aspirate the subretinal fluid, the viscous subretinal fluid, before removing the membrane over the surface of the retina, because this viscous fluid make me like a stuck for the retina to support what I'm doing while I'm pulling the surface. That's what's happening while the silicone is there. If you remove the silicone, the glue will be fluid, so you need to put a PFCL, and you didn't expect where the PFCL will going. It's like a luck if you have to completely sure that you remove all the PFCL and you didn't have any missing particle inside the retina or subretinal space.
Thanks a lot.
Thank you, Dr. Hanson.
So we because of lack of time, we'll quickly shift to the next session. Thank you.
So very good evening to all. I'm Dr. Kshetra and so I would be asking the speakers for the next session. And the first speaker we are having here is Dr. Henry Ruban. And let me give you a brief introduction about Dr. Henry Ruban. He is currently the president of the Ukrainian Vitreoretinal Society. He in Kiev as the head of department of the retina, and was also across United Kingdom, Germany, France, footprints all over across the globe. And his area of special interest is proliferative diabetic retinopathy. And today's talk, he's going to give tips on management of chronic tractional retinal detachment secondary to proliferative diabetic retinopathy. And with this, I hand over to Dr. Andy Ruben.
Thank you so much. Do you see my presentation?
Yeah.
Yeah. First of all, dear friends, I'm sincerely grateful for the invitation to participate in Ophthalmologica 2023 among such great team. It feels like playing for the Brazilian national football teams. It's a great honor and pleasure for me. First of all, I would like to present my clinical case. It's a man, 45 years old, with type 1 diabetes. His right eye had diabetic proliferative retinopathy, mild cortical cataract, and severe chronic tabletop traction retinal detachment with a massive epiretinal fibrovascular proliferation and subretinal hemorrhages and exudates. BCVA 0.02 and intraocular pressure 14. Unfortunately, even 30 years after the recommendation of the ETDRS study, we still see such cases in Ukraine. His left eye had diabetic non-proliferative retinopathy and BCVA 0.8. Aflibercept 2 mg was administered 5 days before the surgery, and 25 gauge phaco-vitrectomy was performed. Anterior elevated leaf of the posterior vitreous schisis was cutted, and the segmentation of the fibrovascular membranes was performed. In such cases, very useful bevel tip cutter design, which allows closer proximity of cutting port to the retina. Fortunately, we did not account it as serious hemorrhage, thanks to the preoperative administration of anti-VEGF drug. But we still had to use endodiathermy. Then the fibrovascular membranes were eliminated bimanually.
Andrei, would you use perfluorocarbon liquid to separate and help in separating the membranes?
Sometimes, yes, of course. If possible, I would like, sorry, I will stop a little bit. Yeah, it's very, very useful, of course, but in such cases, I don't use PFCL. What was the moment? I will be used a little bit later, and I will show you in a minute, okay? The presence of large amount of massive subretinal exudates and blood made it impossible to count of achieving a satisfactory anatomical and functional results. So it was decided to perform a nasal retinotomy after careful shaving of the vitreous base on scleral depression. Then step by step, we began to remove the subretinal membranes, both mono and bimanually. Notice how tightly they're adherent to the retina. I decided not to extend the retinotomy further, inject PFCL. Yeah, and frankly, this picture did not look very nice and promising. Next, 360-degree laser, but it was not panretinal coagulation because there was still enough subretinal fluid and exudates with blood remnants under the central retina. In addition, the nasal retina was partially dislocated, and I would not like to fix it in this position. Finally, direct PFCL silicone oil replacement was done. Silicone extraction with ILM peeling was performed in 5 months. Unfortunately, the fundus after silicone oil removal was quite good. The retina was attached and the remnants of subretinal exudates were absorbed. Visual acuity improved to 0.2. During follow-up period for persistent macular edema, the patient received 2 times Ozurdex and 7 times aflibercept 2 milligrams with a good response to the treatment. Today, the anatomical results remain good, but the macular edema continues to persist. We know that vitrectomy with ILM peeling plays a significant role in the treatment of diabetic macular edema. Also, as evidenced by DRCR-NET protocol D study, retinal thickness was reduced in most eyes after vitrectomy. However, median visual acuity remains unchanged over the 6 months follow-up period. Quite often after severe diabetic vitrectomies, we observe macular edema that is enough difficult to treat. Therefore, I would like to hear from our opinion, the opinion of our expert on these issues. In my practice, I use the same basic approaches as when managing non-vitrectomy diabetic macular edema, and first line is intravitreal anti-VEGF. I don't use a focal laser because the DRCR-NET protocol I study demonstrated that visual acuity outcomes with intravitreal anti-VEGF therapy were superior to outcomes with a laser treatment for center-involved macular edema. The goal PRP treatment are to control ischemia and reduce ocular VEGF levels. That's why sometimes I combine anti-VEGF therapy with PRP based on premise that initial anti-VEGF therapy will reduce 1/3 or worsen diabetic macular edema, whereas the effect of PRP will last for years without the need for long-term intravitreal injection. But sometimes the treatment of peripheral non-perfusion with scatter laser photocoagulation does not improve vision or retinal thickness. Fortunately, I did not meet cases when after PRP, the macular edema worsened or peripheral visual field loss occur. Corticosteroids are alternative agents for eyes that are not candidates for anti-VEGF therapy, or in some eyes that were incompletely responsible for anti-VEGF treatment, but rates of cataracts and glaucoma are also higher in steroid-treated eyes. And of course, to maximize final vision function and prevent progression visual loss in eyes with diabetic macular edema, ocular therapy should be considered in parallel with medical management. Thank you for your attention.
Great case, Andre. This, as we know, is starting the Retinosom session, and I'm so honored to have you as the first speaker. And I have to tell you that this case was so amazing that could possibly be elected for the best, because you virtually made a miracle in this case. You had such a tabletop covering the macular area, and now you have such a beautiful retina, even though the retina did not, it got good, but the vision did not that good, but got better anyways. And congratulations, and I welcome everybody here for Retinosom session. I see here André Jucá. Hello, André, how is it going?
How are you doing, Hudson? Nice being here. Congratulations for your case, Andre. It's amazing.
Thank you.
Great case.
So I would like to ask a question to Dr. Andre, that after, you achieved such a beautiful outcome, anatomical as well as functionally not that good as expected on the expected lines. So why did you choose to remove the oil within 5 months itself? Where we have done such extensive retinectomy and went subretinal. So wouldn't you have preferred to keep the oil for a bit longer? So generally, what is your time duration for keeping the oil in such complex cases?
Thank you. There are several questions which I should to answer. First of all, it's attachment of retina, is how perfectly they attach. It's the first question. The second, in such patient was persistent macular edema under the silicone oil. Unfortunately, such cases, I can't inject anti-VEGF drugs. For my opinion, it's very difficult to inject, for example, in silicone oil, which prescribe some of my colleagues. I never did it, do it. But as a second reason, and in our country now, it's a difficult situation and war. And this patient was from another city and from Kharkiv and enough near to battle line. That's why we decided to perform such surgery, not delay for a long period of time.
Thank you. Thank you. That was really a very wonderfully managed case, sir. So we should move on to the next presentation for the paucity of time.
Okay.
Hello, everyone. Can you see me, hear me, and what my...
Hi, Jorge.
Hi, Jorge. Yes, nice.
So good
Nice,
to see you, my
perfect.
friend. It's a great chance to join you. Oh, thanks so much for inviting me for this distinguished meeting with so great colleagues. And I'll try to discuss about the inverted internal limitant membrane flap in the next minutes about the macular hole. And my disclosures, collaborate with Iveric Bio. And just start with the beginning. The beginning was Wyndham Kelly, who was the first one to introduce us that vitrectomy can fix macular hole. That was the beginning of the 1991. And after him, Eckert in 1997 published a paper saying that we're gonna have much better results after you peel all the internal limitant membrane, 360 limitant membrane. And this really expand the closure. They get more than 90% macular hole closure. And why we need to remove internal limitant membrane? Does it less reoperation? It's safe for every case. Some questions about what we have been done. And it's good. Remove all possible traction force that happens surround the macular hole, the tangential force that make the pathology. Enhance the glial proliferation, and then we're gonna help us close more holes, as the papers have been published. And the help ratio is very low. We don't have reopen of the hole. And the visual acuity looks much better when you remove internal limitation membrane. And some papers that compare if you peel or not to peel the internal limitation membrane, and has shown at the conclusion that we have much better result when you peel. And help ratio is much low, as I said. And here is a PET survey that we did in Brazil, 2012, and the majority of the vitreoretinal surgeons, they choose to peel all the case, more than 70%. But when you peel, you remove not only the internal limitation membrane, that's the footplate of miolar cells, but also we can conduct the dissociation optic nerve fiber layer. And sometimes you can have some damage in the deep vascular plexus of the retina. So far, we have no vision problem after internal limitation membrane peeling or even microperimetry problem, but it's a kind of trauma that we produce. And in 2009, Jerzy Nawrowski and in his daughter Zofia Michalewska, they published the first paper introduced us to cover the hole with the internal limitation membrane, the inverted flap. And after that, we have also a temporal limited inverted flap. And this is a paper that compared the two techniques. The one technique, we do the 360 peeling, and just little piece of the internal limitation membrane, we just cover the hole. The other technique, you just get a little piece of the internal limitation membrane from temporal side and just cover the hole. And just to show the technique, we have to just remove the vitreous, and after this, it's good to stain the internal limitation membrane. Here in Brazil, we do a lot with brilliant blue. Used to use Indocyanine green, but it's much expensive. And just cover like a hinge. And then we have very good results with that. And then how these things happen? The hypothesis is that the internal limitation membrane can make a scaffold for the glial proliferation. And also you can just seal the hole from liquid come from the vitreous, and this can help close bigger hole. And have many papers also using the inverted flap and temporal flap for myopic macular hole. It's something sometimes very difficult to close. And if you compare the internal limitation membrane and the other technique, is quite the same. Here we are some large holes that we are using the internal limitation flap, and they close much good. Here, some papers comparing only peeling the internal limitation membrane and with the inverted flap, the temporal inverted flap. And if you notice, the inverted flap is a little bit better result than just peeling the macular hole. And also we have here with high myopic patients, we have much better results with inverted flap. And just show you the technique, you go something like 200 degrees temporal, and just make a little flap for the temporal inverted flap. You don't need to remove all the limitation membrane. That may cause trauma in the papillomacular blunder. And the idea is we don't need to use a missile to kill a bird. And then intermittent membrane is a good technique, I agree, but it's not necessary for all holes. Our inverting temporal flap is easy, is safe, and you can close the majority of the hole. And just remember you that we have a big congress in Brazil next April. And next week, we're gonna have the MION conference in Dubai. Thank you so much for inviting me for this great meeting.
Thank you, sir. That was a wonderful talk. Yes, questions?
Dear George, first of all, thank you for your beautiful presentation. It's really amazing. And your approach suggests 37 experts from 21 mainly European countries when they published in Macula Hole Delphi consensus statements that for macula hole more than 500 microns, vitrectomy with temporal ILM peeling and inverted flap is the best approach. But for my opinion, in my practice, I never use such approaches in primary surgery except on high myopic eyes and traumatic eyes. Why? First of all, because inverted ILM flap technique, it's not a unique technique, but a family of technique with a many permutation. Someone performs superior flap, some inferior, some multi-flare lap, for example, as dear Professor Hassan Mortada. Second, inverted ILM flap technique has unsatisfactory anatomical result if not consider so-called flap closure and flat closure cases. Third, the mean final best corrected visual acuity according to literature after the inverted flap technique for large hole extremely rare exceed 0.4. It's not so high result. The postoperative recovery rates of external limiting membrane and ellipsoid zone after the inverted ILM flap technique are lower than those in the ILM peeling group, which confirmed by work Iwasaki and Carmen Baumann. You will find hundreds of OCT images that confirm that ILM flap technique is accompanied by a high level of abnormal post-op foveolar status, which secondary intention while healing. For me, it's also very important. In addition, the cluster of cells that formed on the ILM may lead to macula pucker formation with vision loss following an inverted flap technique. I have seen such cases, and they have already been published in the literature. And of course, I agree with you completely that it's not necessary to peel ILM, especially beyond the arcade in a great amount, maybe no cases. But my own result, where we published in last year in Clinical Ophthalmology, for my opinion, much better than in colleagues who use ILM flap, for example, in Ukraine. But it's a very discussable question, and thank you so much for your beautiful presentation.
Andres, thanks so much for a wonderful comments. You explained almost everything. You have just published a very nice guide for macular hole. This wonderful paper. Thank you so much, and congratulations. And you said many things that's discussable nowadays, and why nowadays I'm using temporal inverted flap, just because it's easy, because I can close almost 100% of the case, and that cause less trauma. And also, if you have a persistent macular hole, we still have a limitant membrane that you can reopen and just peel everything and just have some part of internal limitant membrane to recover. We have also the flat closer, but after one year, the majority of this case with the flap closer, they just go fine. They improve the healing, and the macular hole almost all closed. And we have very few cases of flat open. And that's a problem, but this happens more when you get huge macular holes, not macular hole until 500 microns. But I agree with you, it's very discussable and have many different experience, people that love to do the 360 interlimitant membrane peeling that has a very good results. And the trauma that caused the dimples, so far we don't have really proof that's gonna cause any damage in the vision. But thank you so much for your comments.
Thank you so much, sir. I guess in the interest of time, we'll go on to the next presentation.
Thank you.
Thank you.
Yeah. Hi. I would like to thank you for inviting me, and I guess we are going to keep discussing the subject of macular hole. I just brought this. I think that we all agree that the standard technique for macular hole it's just suitable for the great majority of cases. We have very good success of 96% with the standard technique that includes parasplanavitectomy, internal limiting, membrane peeling with triple blue, like in this case. We think that, excuse me, in some cases, it's important to remove the internal limitant membrane from the border of the hole, excuse me, avoiding the contraction of a ring. So this technique is great, but I think that in some cases, when we have to, in the exceptional case, then we have to reoperate the patients. Then we must try something different. Like in this case, we are doing macular hydrodissection. Of course, when there is many techniques for very big macular holes or for reoperation cases, we must change. I'm not going to talk about IML flaps because I think George Rocha did a wonderful job just before me. But we have also the option of autologous retina transplantation. But I think that maybe the retina is not going to work, and using retina to create a plug, maybe it's not reasonable to use a novel tissue just to create a plug in the macular hole. So maybe the human amniotic membrane graft, it's a good option for these very, very large macular holes. Indeed, the close study group that was done by a group of experienced surgeons and our friend, the Brazilian Flavio Rezende, showed that in the cases of a very, very large macular hole, that the one that above 550, we should try to do something different because the rates of this closure of the holes, they begin to diminish a lot in these very big rows. So we have these options in these cases. And here we are removing this with a punch that is used to hair transplant or hair implant. We just do that and take this small amniotic membrane. Amniotic membrane is being used in the human body for reparation. That is more than a century, and it's very safe. There's no report of infection. And most of the amniotic membranes, all the patients, they do search for HIV, for hepatitis, and the woman do this screening. So there's no reports for infection. And indeed, the amniotic membrane, it has some properties that it's antibacterial So it's used in the eye for a long time. For more than 70 years, we have been reporting on using it in ocular surface. So it's a very safe tissue with a very, very low rate of complications. There's no reports of reinfections known in the eye. So we have this publication. This first publication was done by Rizzo, showing the amniotic membrane that he puts in the hole above the retina surface. So we see here the membrane, and he showed that in the border of the hole, there was good sensitivity. Although that in the center, the sensitivity was not good, because maybe the membrane itself is impeding the migration of the cones for the center of the fovea. We had this case here, was an hair operation case. The guy was doing a surgery and the patient moved and he touched the retina. So we have this very big macular hole. This is the gas. It's extra large macular hole for the macular hole study group classification. So we decided to do what we could do in the surgery. And we did find there was some, there was not a lot of, this is the arcade, so there was not a lot of limiting membrane. There was you see the touch of the instrument during the first surgery in the pigmental epithelium. So we're looking for more tissue, maybe glial tissue in the border. And as you see, we could find any. Anyway, there was some discussion about making, in this big case, little cuts on the edge, and we were trying to make that to facilitate the edge closing. But it was really a big hole, and we feel that this was not enough. And then we thought maybe with macular either section, we put some perfluorocarbon liquid to avoid the fluid going out. And we did this hydrodissection. Although with the hydrodissection, still we thought that was not really enough. There was still a lot of, was really a big hole. So we just try something else. We just put this amniotic membrane tissue. So we are mixing techniques here really to try to, you see, this is the amniotic membrane that we just painted it with trypan blue, and we are using Alcon finesse under perfluorocarbon liquid to dislodge it over the big macular hole that we got there. So the idea was not putting under. This is 2 millimeters. You see that when we cut it, it's very small. It's very small piece, and when we cut it, it's not all round. It's a little bit, but doesn't matter. The idea is just to cover the hole. So we put there, and finally, we are going to remove the perfluorocarbon fluid. And at the end, to avoid dislocating, we just put some biological glue that's made of fibrin inside the eye, under air, under tamponade gas. And this is how it looks. This is how we cut it at the first, and this is how it looked after a month of the surgery. You see the membrane over here and over the retina surface. And this is an option, not for every case. I do think that the traditional technique that was described by years ago, and when Eckert made the improvement of removing the internal limited membrane, this may be an option for very special cases with extra large macular hole, as the closed study has shown us so well. Thank you for your attention.
Congratulations, André. Such beautiful case. And it's not easy to to cut the amniotic membrane very, accurately like that and put it into the hole. And you've got such a good visual acuity as a result. Congratulations, very nice technique.
Thank you very much.
Any question? Yeah. So we will start the fourth. We will start the fourth talk of Dr. Hudson from Brazil.
Oh yeah, let me share my.
Yeah, Dr. Hudson is we will have short talk on him. He has done 2 vitreoretinal fellowship, one in Toronto and one in his own hometown city in Guinea. I don't know if I mentioned the name is right or no.
Yeah, it's Goiânia, the city in Brazil here. Goiânia. It's a different way to.
You can start,
Can you
Dr.
see
Hudson, please.
my screen? Yeah.
Yeah, please. We are waiting.
Yeah. First of all, I want to thank you very much for letting me in, and I want to thank VIPEP SETI for doing this session in Retinosom here in Ophthalmologica. We've been participating since 3 years ago, and it's very good, and I feel very awesome with that. Thank you, VIPEP. Thanks, everybody. And I'm going to show you such an interesting case of surface retinal diseases. Let me just try to move these. Can you see it well?
Yeah, we are seeing, sir. Please go ahead.
Okay. So I have some thoughts from surface retinal diseases. You not always should think you have the best technique on surface retinal diseases. And of course, every case is difficult. And we have here Gabriel Medina, it's a world champion in surfing. And he says that sometimes you surf well and still don't win. It happens to everyone. You think the case is easy, sometimes it is not. So sometimes you surf well, sometimes you operate well, and you don't win. That happens to everybody. So the best thing is that you have this backup. So I guess every rookie learns that time goes by. It took some time, some big lessons from my losses, of course, and you've got to go with experience and do the best technique. And I'm going to show you this interesting case here about vitreomacular traction. And sometimes you got to decide whether to operate and whether not to operate and what to do and the right time doing the surgery. In this case, I'm going to show you out of this YouTube presentation here. This is a vitreomacular traction case, very taut membrane. We are at the Eye Bank Foundation here in Goiânia, Brazil. And the hyaloid was very taut, and we used brilliant blue to peel the membrane. You see here this traction, vitreomacular traction case, the OCT showing a large defect in the central area. And fluorescent angiography and FAF peaks show the membrane was deeply rooted, as you see here, putting all the foveal structure above. And so things were getting really worse over time. So we decided to do vitrectomy. We got to be very careful because the patient is a phakic. After doing core vitrectomy, the best thing after doing core vitrectomy with the wide-angle vitrectomy viewing systems that we have is to have a very good look at the retinal periphery. And then I like using the contact lens, a macular lens, to see the membranes. If you see it well, it's not necessary to use, in my point of view, dyes for the vitreous. As you see here, I can, with the macular lens, grab the tissue very well and actually separate the hyaloid, attached hyaloid from the retina itself here. And you see how brilliant it comes off the retina, the reflex, and the hyaloid is very taut. Still, with the appropriate lens and contact lens, is it possible to lift it up without damaging the structure? And you need to have in mind your OCT. You just don't have the OCT to keep it somewhere. You gotta take it to the OR and think of it, and if necessary, you should print it in a good paper and do the surgery with OCT, because we got to go very easy here in the foveal area. Otherwise, we could lift it up and lift everything and damage the foveal area. So after this air fluid exchange, as you see here, we like using, as Dr. Jorge Rocha said, we love using here brilliant blue. It gives a very good staining. It's cheaper. And I do a complete air fluid exchange.
Hudson, is that
after a complete air fluid exchange, and you insert the brilliant blue, you see everything all clear. Now we have the macular lens. So it looks like the retina is inviting you to choose the appropriate place for the peeling. And of course, the lens should be avoided at all times. And so with a good retinal forceps, nowadays I've been using 23, 25 gauge ILM forceps. So this is not the pinch and pray technique. Some people say it's pinch and pray, but this is a pinch, and very slowly you turn around the retina and remove the ILM in the circular fashion. You gotta be very easy on that. You've got this great image. And after we remove all these ILM that causes attractions, the results get a lot better. And they remove the attraction. I use the same technique for macular holes as well. Sometimes I use stuffing technique. Sometimes I just put the ILM on the hole, but this is not a hole. So I still use the technique. I like doing laser around the retina just to make sure the retina will be attached and we did not cause any inadvertent retinal peripheral break. So after these complete AFX, and you're going to see the results shortly, and the exams that the patient kept faking all the time, and you have here the FAF peaks and color, and everything is so beautiful. And when you see the OCT crossing over the macular area, you see that all traction is removed. Looks pretty normal. And as you see here, the postoperative period looks a lot better, and we compare the before and how it looks like now. So the vision got to 20/80. So the rule of thumb here is not to peel very forcefully, to peel it very gently, and avoid at all times getting much of the tissue. Otherwise, you could probably have a retinal tear, and you have you go too forcefully, you could have this problem. And I have another case here that it's a very interesting and a quick one as well.
Okay, my case is
a little forward to show you.
So
these are just steps for doing the posterior vitrectomy And when we talk about surface retinal
membrane and internal
gotta
limiting
tell
membrane.
what the membranes are and how
temporal
could we
sclerotomy,
well manage
3.5
the
to
membranes
4
without
millimeters from the
damaging and
limbus
actually
made
seeing. And when I was telling you about the OCT on the side, it's very good to have the OCT. Otherwise, you won't see a thing there. You think you're going to be
we start the core vitrectomy of the central vitreous.
And you see here the
you
reflex
can
of the retina.
hyaloid reflex of
And you see
the epiretina from its
the
adherences
vitrectomy, you
to
remove the
retinal
core
surface.
vitrectomy. Now you grabbed the
After
hyaloid
that,
that was
we
already
carry on the
removed, and
vitrectomy,
this is very taut, as you
with
see
the
here,
curve,
like in the
we
last
grab the
case.
posterior hyaloid
And now
in the
this is very
macular
important.
area.
When you get to the foveal area, you gotta have the OCT in mind.
You may notice
and in this
attached
case,
tomography,
I display you the OCT over here, and how much the retina is detached, and everything is so elevated. And so be very careful not to tear the retina at this time and remove the retinal tissue, the retinal tissue, the retinal membranes, and then after seeing actually with the contact lens, you see whether you are doing more or you're doing less. And after you remove the epiretinal tissue, this is another case where we use the brilliant blue by doing the complete air fluid exchange. In my experience, when you do a complete air fluid exchange, you have the best likelihood and the best option to stain the ILM very well.
To be removed.
All of this
in order to relieve the
macular area, as you see here,
in the OCT example.
And I'm focusing here now
we have
on
here
the retina and very bluish tint
with brilliant blue.
And now it's possible to grab, like an invitation, get me out. So this is the foveal peel, and of course very difficult, like starting from the foveal area, because the ILM there is thinnest. It's like 0.33. American is very, very thin. And, but anyways, if you've got an edge and you keep following the edge, and it's not going to happen, any problem is going to ensue. So you just need to find a good edge and keep it going there. And now I'm enlarging the central and also the peel, as you see here. So you got to be very careful. But when you get the edges, you see very well. So just keep getting them and grabbing them where you finished, in case they just did not go through at once. And so now just approaching a little more, and we have this case that we removed.
After this,
the membranes and another air fluid exchange. For this case,
endolaser barrier at the retinal
performed, and the laser, I like the laser, like here, the patient has
these
white without pressure
retinal membrane,
just to
as well
protect.
as the internal limiting membrane, so that the traction
here
is much
removed,
less.
And this is another fake patient. Look at the traction
the
and the membranes above, and look like how it looks like it's still getting better after the post-operative period.
The macular area
patient,
and the return to the normality.
Better and very happy because
and
we
fluorescent
removed
angiogram show 10% gas
from
the absence of
macular area.
edema.
Virtually, you do not get edema.
Thank you very much for your attention.
That's the case, and just to complete this presentation here.
Okay, thank you, Dr.
I will
Hudson, for your
show
nice presentation.
These slides in order to invite you for Ophthalmo Cordoba in Cordoba, Argentina this month, in 2 weeks. And I thank you very much for this great session organized by the Seti family, right now some special session over here. And I appreciate being here. And Pan Ophthalmologica is like part of my family as well. And I feel deeply appreciated for being with you guys. Thanks a lot again.
Okay, thanks a lot, sir. Thanks, Dr. Hudson, for your nice presentation. I think before we leaving this session, we need to talk regarding with Dr. Andre regarding amniotic membrane grafting in the large macular hole surgery.
Sorry, I didn't hear. What about?
Regarding amniotic membrane transplantation and extra large macular hole.
Yeah. What about it?
Yeah, I'm talking you from Yemen. We have a lot of victims of war, actually. War victims has had traumatic macular hole that it be more than 1,000 always. The macular hole always more than 1,000. Actually, I'm trying this since around 6 months. I'm trying to do this amniotic membrane transplantation and extra large macular hole. Actually, I did more than 3 or 4 cases up to now. I'm getting only anatomical success, but I'm not getting any functional success until this point of time.
Yeah, most of the patients that I think trauma cases, they are another thing, isn't it?
Yeah, it is another chapter of life.
Yeah. But most of the patients, did you ask them if they think that the vision is, the scotoma is smaller? I remember I did a case of a patient with anterior lenticon and a big macular hole. And although I closed it and I couldn't notice that the vision improved, I did the microperimetry and I saw that the scotoma was smaller, and the patient itself, it told me that it was better, but I couldn't measure because the visual acuities are so small. What I do suggest that do microperimetry before and after the surgery, so you can get some visual function results.
Improvement.
Yeah, because if you rely on visual acuity, maybe it's not the best.
One question more I have. We have 2 varieties of amniotic membrane. We have with amniotic membrane, we are still getting it from the mother after delivery immediately, and the one dry amniotic membrane. Dry amniotic membrane, they use it,
Yeah, I think I lost the connection.
No, you're right. I think he lost the connection, but he's connecting. Abdullah, can you hear us? I think he's got a little frozen.
I have no experience with dry amniotic membrane, but I get a fresh one because in my hospital we have just a hospital for getting babies just beside it, so it's very easy to get them. You have to get from cesarea, not normal labor, because it avoids contamination, and it's only, and of course you have to treat it with antibiotics. They do that over there with amphotericin B, neomycin, and erythromycin, and they using vancomycin now because they say there is a lot of resistance against penicillin as well. So we treat it with antibiotics and remove it with a blunt dissection, and then you have a lot of tissues for many ocular surgeries. You can preserve it for over than a year if you put it in liquid nitrogen with negative 80 degrees Celsius, so you can preserve it. And it's very cheap, it's not, and it's widely available because babies are being born everywhere, every time.
Andre, very interesting. How will you get these membranes? How people from the obstetricians, and how do they get it? And do you have the technique? Do you have the partnership with the hospitals? Could you tell us?
Yeah, just the resident just go there to get the piece because they have a lot of it. It's not only ophthalmology that use it. Guys from plastic surgery that work with burns, they use it also. It's good for them too. So it has a widespread indication of use in ophthalmology as well for pityriasis. The guys that talk with the guys that do ocular surface surgery for cornea ulcer. There's many indications in the guys are using it for a long time in ocular surface ophthalmology, and of course in other specialties than ophthalmology as well. So it's easy if you get a big hospital where they get the moms and babies, and it's widely available and it's not expensive. It's a little, you just needs a little bite, and we have the tip that I give is try the guys that do hair transplantation. They have this round. It has 2 millimeters to do the hair. They do not use it anymore. Before they use more because they know now they say that the aesthetical aspect of hair transplantation is no good with that. But they still, the hospital still has it. So I just take the punch. And perhaps it's because it's not very round, because it's an old punch, and to do that round, about round, but it doesn't matter once it cover, and the lights comes through easily. It has been shown in many studies.
Yeah,
it's like a Band-Aid.
Andre, can I ask you?
We are missing your case. What have?
Yes. Dr. Ruban, please go ahead, yes.
Yeah, sorry. My question about some transplant, what is happened during the time? Is it a change in size, or some became bigger or smaller, or something, or the same?
No, it stays the same. It does not change with time. It's indeed this can last. I think will last forever. It's not going to go anywhere. It's made of. It's very good to. The only thing that I was afraid of is getting an allogenic response, and but it does not happen very often. Although there was one case that I read in literature where the guy got an hypopion, and was a sterile hypopion, so they thought was from this allogenic material, but there was only one case that I read about, and it's very safe. Otherwise, it's used to fight against infection because it avoids biofilm formation from Pseudomonas and other bacteria. So it's very safe in this aspect, and it has been widely used. And if you put under, you're going to avoid the migration of the iOS segment formation, and the cells are not going to migrate because the tissue is there. But if you put on the surface, it's going to work as well, and you do not bother the migration. So I think you may get better results. I don't know if Abdullah, that was doing the traumatic cases that I haven't done yet, he's using under or over the retina. And there is a tendency of gluing already the chorion face of, because there is this base membrane and chorion face of the amniotic membrane. The chorion face, it's very sticky to the membrane anyway. But nevertheless, I put the glue to avoid dislocation, because there was some reports of the dislocated membrane afterwards. In my case, it never dislocated and never changes the time as well. There is a little of debate of using retinal transplant, but I think the retina is not going to connect with the optic nerve, the transplant tissue, I mean. So it's going to bother the migration anyway. And besides that, it's a noble tissue that you're cutting just to use as a plug. So for me, using the amniotic membrane makes much more sense in this very big macular hole case that otherwise the surgery may fail in a high percentage of cases.
Thank you so much. Great job. Amazing.
Andre, let me ask one last question. Sorry. the membrane in order not to avoid the migration of the RPE and the forming of the RPE. Do you think the membrane could better off being with the small holes, not to halt the growth of the RPE at that zone?
Yeah, there is some guys that are using it in diabetic as well. The guy, when you get, you should try to do the surgery as Andre did without getting any posterior breaks. But sometimes it happens to get a posterior break in diabetic, and the guys are using amniotic membrane to avoid fibrosis. And I haven't used it yet, but maybe it's a good idea to avoid the migration. It has also an activity against fibroblasts. It has been shown in the skin and in other tissues in the eye as well. So it may be useful to avoid PVR as well. So we never know. Has been published in diabetic cases anyway. The use of amniotic membrane in posterior rupture cases in iatrogenic holes that we always avoid to make, but now and then we have it. Yeah.
Thank you. And we had a wonderful, wonderful session. And I'd like to thank all the speakers of Retin Awesome, Dr. Rocha, Dr. Anajuka, Dr. Ruban, Dr. Hudson Nakamura. And with this, we end Pan Ophthalmologica. And I'd like to thank everybody, all the speakers, all the panelists, all the moderators for putting an amazing show. And thank you from the bottom of my heart and from Team Arunodaya, and hope to see you again soon sometime. All the very best.
Thank you.
Thank you
Thank
very
you,
much.
Thank you. Thank you.
Thank you.
You are awesome.
Thank you very much.
You did a great job, man. You did a great job.
Thank you.
Dr. Andre, regarding
There's still questions coming.
Yeah.
I think he's again frozen. I'll send him a number. He'll message you. Question.
Yeah.
Good night. Good morning.
Yeah,
good night.
thank you.
Good afternoon.
Thank you. Thank you all.
Thank you, teacher. Thank you so much.
Bye-bye.
Bye-bye.
thank you. Thank you.